basically getting up here and getting up earlier than most of us probably usually do. But it's we felt that in order to make sure it's around the world that I know our friend Lovely in Philippines is it's 12 hours later, so we wanted to make sure we get a.
Yeah, in 1 minute exactly 15 people have joined.
Okay, well I think we're ready.
I'm watching the numbers.
Yeah.
Just go ahead. It's fine. We just.
Well, as has been mentioned, we've had a wonderful day yesterday, and there was so much. There was so much coming our way. It felt like we were trying to take a drink from a fire hydrant. It was just, the information and the was just gushing out in a wonderful way. And I'm so grateful to the speakers that helped us, did a wonderful job of presentations. And today we've got a really fine lineup of speakers, and there's more focus on the implementation of parenting and especially learning through play. And as we mentioned yesterday, the research and implementation go together. And I think that's one of the things that's made the parenting programs and learning through play so strong, is the way that we've combined and we respect both those at the front line who deliver learning through play and those who are doing the very sophisticated research and evaluation. And so I think it makes it all better for parents and children, of which we are so grateful. It's my joy to introduce my good friend, Maya Gayatonde. We've been friends for 25 years. Balamandir in Chennai, India, was our first international partner. And Maya was very gracious to Hinks-Delcrest, which is now Sick Kids, and she taught us, in a sense, how to be a good international partner. She'd say, "Oh, you got to watch out. You got to protect your intellectual property, and don't trust everyone." And she taught us how to be open to changes within it in the material, and yet maintain the main key messages. And so over the years, the relationship has grown stronger. We've been watching her and Balamandir extended across India, so many different communities and languages, do the translations, and it's just been a joy to watch their activities, and it's been a joy to relate to Maya and her team. Maya is the Honorary General Secretary of Balamandir Kamaraj Trust, and has been for many, many years. Balamandir is a premier social welfare organization established in 1949, providing shelter, care, rehabilitation for children in difficult circumstances and from socioeconomically weaker sections of society. She is an LTP master trainer with over 20 years of experience and the coordinator of the LTP program in India. She has been instrumental in formulating Balamandir's parenting and ECCD training curricula and conducting learning through play trainings for a wide range of groups, including parents, creche and kindergarten teachers, partner NGOs, and government departments. I'm so happy to welcome you this morning, Maya, and we look forward to your presentations. I should mention one more thing, that Maya she's a historian, so she has a broad view of things, and she brings that skill as a historian to learning through play and has done some great articles on the development of it. And so, Maya, welcome.
Thank you so much. Thank you for this wonderful introduction. Could I have the presentation? Yeah, just go to the next slide. Next, please. Okay. She just put in, we put in an agenda. I will go as per the agenda and try and stick to my time. And here are the children from India saying hello to all of you. Yes, please go to the next one. Andrew did talk about Balamandir institution established in 1949. And here there are things he mentioned, all the work that we do. But I think what is very important that our founder took a very, very important decision in 1949 to admit children below the age of 5 into an orphanage. Now, that's the only one of its kind in Tamil Nadu. We have just one other institution. But she felt that that's when the parent or the mother in distress or the family in distress needed the most help for that child below 3. So, in fact, most other institutions in the country, they take in children only after 5. Of course, adoption agencies do take it. So that was significant. So when early childhood came to us through learning through play, just give the next slide to the BMRF, to the BMRF, that was an adjunct. And that was the first international partner. We were two separate organizations, two sister organizations. It just made a lot of sense for an institution that had already done over 50 years of work with little children in the orphanage, little early childhood. We were the first international partner, very significant day, 1997, when Andrew and Ramani walked into Bala Mandir, and from there onwards, we've had this wonderful relationship, and we were so happy. The children's happy faces do tell you that, you know, LTP has brought a lot of happiness to wherever we have been able to share it with the parents and the children. The next one, please. Now, when you see this LTP expansion in India, please, I just want you to look at the map of India for only this reason, that every colored state, every one of them, has a very, very clear-cut language, cultural differences, nutritional differences. Of course, we are one country and governed by one, the central government. But this was something that we first learned, and that I would say we learned from LTP, because it came from Toronto City, and we were quite thrilled to know there were already so many language translations. And now the stars just tell you where we are. We did our work, where we have translated, and you can see there is so much more that has to be done. But wherever we are, we started working. Can we have the next, just for you to know that this is so important, that and the sensitivity to the culture. Now, what was that project model that we defined and have now stuck to over so many years? The next one, please. We believe that this parenting was a right, child right, that the child has a right to an informed parent. On the other side, the parents, under the right to information, they have a right to know everything there is about their child's development. It's almost like it's equal rights. So it became for us a way to take the rights issue, both for the adult and the child, forward through the LTP program. The next one I would like to say is that we went and defined the word parents. Now, it sounds very simplistic. Of course, everybody knows Papa, and then you know all the other words, but A for Amma or I, or as it meant the mother. And so you have the Papa, you have the mother. Then we realized that in our societies, particularly in India, relatives and the elders, the grandparents, make a very important support system for the growth of the child. And therefore, the messages equally needed to go to them. And then you had the neighbors, because they form the community in which the child grows up. And then when we use the word teachers, you can see from the definition, we looked at those creche work. Actually, when we use the word teachers, we talked about the creche workers. And you know, India has integrated child development schemes in the world, the ICDS as they call it. And so there were these workers in the villages across. And I remember when centers, that sounded huge. But in a country like India, if one state has 55,000, you can imagine the number there are. However, what was in the quality, that is what we tried to define. We've been working very closely. We worked with 2 states. And then the most important, the last word is society. And that was something that we, yesterday when Dr. Gutta and all of them mentioned, that these are all issues that need to be of concern to everybody. All the political people, the economic, that these are all, your children are the generation of the next are in the next generation, and they really need to get all the best that they can. Next one. When it came to LTP, all of us know that there is the SPRUC, but it just so happened that instead of calling it SPRUC as it was called in Canada, we used to just say the word spruce. And then we suddenly realized that we'd added an E. And that became very important in our model, that we not only looked at the natural environment, but the child's immediate physical, human, and social environment. And there were changes, and therefore, while the message intrinsically was the same, we adapted it to the living conditions of the child, and we were very focused, of course, in the low economic settings. Next. Next. Can you just press it? I think it comes on. Yeah. So we started to work with government, and then after that, just keep pressing it till, yeah, okay, government. And then we started working with creche workers, that is migrant labor, urban, rural, tribal areas, then with schools. Because in India, the child comes to school very early, and therefore 3 to 6 became very important. And then we, with kindergarten teachers, teachers training institutions, early childhood teachers training institutions. And then there you just have our main work was always the LTP project model was to work through NGOs in the other states. So then we went into orphan and destitute homes, adolescents. Why do I say adolescents? Because we felt that young adolescents getting into relationships, going beyond just friendship, needed to know about all the problems that could happen if children were born out of wedlock, or they needed to be sent into orphanages. There were adoption centers, community health NGOs, women's groups. Now it's interesting, I say the word women's groups also because we looked at the women in the group, either as a mother, the aunt, the grandmother, or the elder sister. And now these were all very important to the child or the children in their homes. And then you were community development. Then we went into certain special needs organizations, even ragpickers, street sellers. We had a vast experience. Just go ahead, please. Next one. Okay. Now I will just divide that from 1997 to 2011, we were directly with Hingsdale-Crist and were given support through CEDA. The first 3 years were the formative years. We were getting to know what LTP was about. 2000 to 2004 were the innovative years. Where can we take this LTP? What are the various areas? And we found so many beautiful environments to which if we became sensitive, it was so easy to talk to them. And the many experts told us, no, these foreign pictures, they were not going to, the rural people will not understand, the tribal people, but that was absolutely not there. In fact, I remember very clearly in Gujarat when one lady, we were just talking, and then I said, don't you find these people looking different? So she said, why do they look different to you? To me, I only seeing a mother with a child, or I'm seeing a father with a child. Why are you seeing differences? And I think that was the kind of, speciality really of LTP. And then we had the expansion years when we made a whole lot of NGO contacts, particularly in the 4 states. And then, of course, between 2008 and 11, we had experienced, and we got all our materials together, our training programs. And I think Andrew will recall the last conference in 2010, where we, brought out the JOP and everything, and we went ahead now. And we knew, of course, that 2011 onwards, it would be LTP India on its own. That was how we thought of it, and that's how it is. And we managed to, yes, let's go to the next. Okay, so I'll just give you an idea. I'm just showing you through pictures, and therefore you just take me through this maybe every 5 or 6 seconds that you could train. You could just change the pictures. So here was one of the ways you can see this was in Gujarat. Yes, and you can see the fathers very interested, as she was saying yesterday, that the father is looking for the windows, but through the windows, we told them, no, looking, come and join. So the fathers would come to live the part of it, and they'll be showing the calendar and talking to them, and in Gujarati. Yes, next one. So one of our partners was NGO. It was called SEVA, Low Income Independently Employed Female Worker. At that time, they had something like 7 lakh members, one of the largest women's organizations at the time across South Asia. But there, it was wonderful. You can see from the way they are dressed that many of them from the tribal areas, some from the rural areas. It didn't matter. All women interested. How can you help me to help my child within my own environment? That was important. There was nothing. This is something which I've said specially, and I think all of you would have noticed. LTP does not recommend any toy that you have to go out and buy. It's everything in the home and things that the mothers can do and make. And so this was they were doing an activity trying to make something for the children. And we're saying that you can do that and help those children. And so that was really the strength. Then was the next place would you like to just? Okay. Then we worked with another group in Karnataka called Sutbag. They were a nutrition focused NGO who were actually working, and they, along with nutrition, we told them very beautiful, you can give the nutrition for the body, but now let's give them some nutrition for the thinking and the brain. And that's what LTP is all about. And here was I would like to just focus on the second picture of this little children there. It was very simple. It's a very simple game which we played. And I think it's something that I would just like to explain that to you. Mothers were told that do not attend to your child. Just sit down. And within 2 or 3 minutes, the whole lot of kids were howling and screaming and all. And then with the little hand we put up, then they started attending to the child. And within a minute or two, the children became so happy. You didn't have to talk about anything more about attachment or attending to children or, responding to their needs. Mothers understood. So these were the little kind of games that, we learned to play with them. So that what we were saying became actually alive. Yes, the other next organization. Okay, and then we worked with, this is very interesting. You'll see those little, the kids there. This is a construction site. This is the migrant construction worker by law. All construction sites have to have creches for the mothers. They're allowed to have. Now, across India, most of the construction workers are migrant, and also their job is such that they may or may not. So the challenge in working there was, okay, that parent may not be available. They may be available maybe 6 weeks while the centering work is done or cementing work is done. In that 6 weeks, what can be? And we had an excellent, the Mumbai Mobile Creches is a very well-known organization. And we worked with them. It was a great learning. So across, we had 3 or 4 states in Delhi, cities, Delhi, Pune, Bombay. We worked with them. And then now the beautiful thing was that every time we passed on the knowledge to a new NGO, they became part of the network for information on parenting, which we had established in 1999. So we kept in touch and we kept sharing and kept enhancing each other's knowledge from the learnings of each other. And then finally, of course, I think you have visited all of these. Andrew visited all of these 3 sites very much so. Can I have the next one, please? Okay, here are some of it on the construction site. You can see where all the wood is there and everything like that. These were the children who benefited from what we taught their mother. Yes, the next one, please. Okay, and then finally was Suraksha in Nagarkoil. I think this one we could not go because of the huge storm that had taken place right down in south. This was a tribal community, and it was very interesting because they had to access it by a boat, but it was just the same. All the mothers, all the fathers, the workers were all interested in this. What they felt was so simple. It was absolutely, according to me, LTP is a low cost, no cost program of parenting for the parents. Really nothing. I mean, I'm sure those of us who are working, we might have budgets and all, but for the parent, it was just look around you. And there's so many interesting things that you can do in and around your home with the child. And that was really the strength with which we moved with such confidence into the community. Yes. Please could it? Yeah. So then these are just, you could go through the next 2 slides that show you that during the tsunami, We used LTP in the settlements to help the mothers through their trauma and the trauma that they had not understood that their own little children had gone through. So really the child care centers that there were child care centers, and there we just taught them the important learning through play. It didn't mean that what could they do through play that could help children through the trauma. Tsunami, was a very traumatic experience, is not only for the parents but also for the just like the COVID now has been such a traumatic experience across the world, and it has affected the little ones who don't really know what's happened to them. But it is now we find, in fact, we're doing a lot of work with that. And then you had, of course, here are just examples to show you the kind of environments in which we have taken LTP. It didn't mean that many of them could probably not read the calendar, but that didn't matter. Even looking at pictures, listening, and then how we developed our resources, that would be something I will share with you. Yes, go ahead. Pictures say a lot. Then we did a lot of interesting intervention, ongoing health and nutrition, early intervention. These were things that we added on. Now, we were questioned that how can you give health? You're not health workers, you're not nutritionists, you're not special educators. So what is it that you're trying to add these three to the what we call LTP plus? The question is that Indian Association of Pediatrics has very clear cut. These are the information that parents will. So I feel an informed parent, that's what we said, every parent has a right to information. So we never said that we could give you a solution, but this is what you should do for the betterment of your child. And then we would send them to the public health center or where it is. Most importantly, it comes later perhaps, but it was at that time that I remember Usha was part of our team. And she said, you need to inform parents to understand their child is delayed. Because tomorrow when the child goes to the special educators, it's the mother they will ask them what happened, or they'll ask the family, what is the child doing or not doing? And that is how this worked. Remember, it was not early intervention, I would say early identification. Early identification that yes, perhaps my child has a problem. And this was a huge knowledge that, and of course that came later on as the tool. So we did a very simple thing with the work. And I think Andrew mentioned yesterday, and of course now we have the IMOW, but I'm saying this was a start where we taught them, and the nutrition. We know breastfeeding. There's nothing in breastfeeding that you need to tell the mother she can do it. Then the soft foods. And in India, remember, we have such a wide variety of millets, etc. That was not something difficult to do, but we never took on the role of either specialists or doctors who would give advice. Yes, go ahead, please. Okay. And then, of course, there were street plays, parenting songs, games, all of this. These are all various things. Just go ahead. We need to move a little faster, I think. Go ahead. So there's the part 2. When we had known Hinks Delquist had moved out, we had permission to use LTP, and then we worked with UNICEF. Now, this was a very interesting 3-district project across the state of Tamil Nadu, 1,900 children, 500 pregnant mothers across 1,102 villages. And it was very interesting. We created a baseline information on the family. UNICEF supported us right through it. And for various reasons, of course, beyond 2013, it could not continue. If you just go through the other slides, I would just show you that what it was that we started to do. These were just pictures. Enjoy them. You will see even little children talking. And then we did the work with Child Fund. Worked across 3 states, 28 of their partners we took, but in rural Karnataka, we took up a specific 1-year project, and there the focus was on psychosocial parameters, early identification, because those villages did have children with disability for some reason, so we looked at that and helped parents to understand what they could do to identify. Yes, next. And these are the kind of interesting, if you see, you'll see all the, and here's a lovely picture of Hema Srinivas. We know she was really the brain behind a lot of the innovations. She's still with us and, our partner in Karnataka. And you can see that everything is very normal here. And this is a beautiful ceremony, please. This is a ceremony which is done across India for the mother who is pregnant in her 7th month. And then it's called the bangle ceremony. It's done differently across India. So we honed into all of that as finding. So this is when a time came when we started looking at LTP plus, and plus meant backwards. So we started with conception. So important that from conception to birth, because the calendar starts with the birth, but then we develop tools and all of that. Just go ahead. So this is a lovely ceremony where the women of the village were doing. Now we've done 2 technical consultancies recently. That was one was both Grand Challenges Canada projects, research projects, and we consulted with based on LTPC. One was with IFMR, who they worked with in order to increase the involvement of fathers. It was a very, very interesting project, even as we developed it, and had a lot of success. Then there was the Christian Children Fund of Canada, now called Children Believe, where they focused on antenatal and prenatal, and then the first 1,000 days. That became an LTP plus. So that was something. And we have developed 55 animated videos for that time, and it's all on the public domain, which we will now, I don't know why, I'm sorry, but we should have put it in, but we will share it. So this was something that was done by Grand Challenges. Yes, next. Okay, and then finally, there was this Michelin tire. I mean, it was a CSR project of the Michelin tires. It's been going on from 2014, and we continue year in and year out. And now we are introducing, just show us the next pictures, because as I talk, you could see the pictures. So first there was just the ICBS center, then we went into home-based intervention, then community-based interventions, and then individual childcare plans. And then the COVID response was really something, a great learning for us, that how much people are now more depending on, cell phones and things like that. And we could use that media. And we have now, I think there was another friend of ours, Lakshmi Gopal, I don't have a picture of her, who developed 2 things. She found that 10th century Tamil literature had all the same ideas that LTP wanted to share. And she brought out a very interesting publication of, showing literally LTP and 10th century Tamil literature. Also, she developed, for the group who are unlettered, songs in Tamil. So if you taught the song, then you knew everything that needed to be known about the stage. And those songs were put into tunes of folk dancing. So women could dance and sing, and they would have their LTP lesson, whether it's birth to 2 months or it was about 2 to 5 months. So it was something. And now we are using this on the, sending it by video, by sort of cell phone to parents. Fathers, they get a little thing that today you hear this particular song and you know about your child. So we know what are the children in the house. And this is something getting to be very interesting. We're doing that. Yes, go ahead, please. I need to. Okay, so there was home visiting. Of course, they said COVID response. It was interesting. Yes, please go ahead. Yeah, and I just come to the last bit. Yeah, just go through the resource materials. I would just like to tell you that this is something that we developed. I'm showing you the Indian languages. It's just lovely to see. Very interesting and looking beautiful, but we have done it, and we will, about 10 of the regional languages. We have done, we're working in some states, we're waiting. Then we developed this guidebook with Hingstelker's permission. We got it that tells you the what, the why, and the how of every stage. And it is an interesting book. It's been translated into other languages, so that it's a complete set. It's somebody who would like to read about it. There are many parents now who just buy it because they're literate, they can read it, they can understand it, and it has nutrition, health. It's a very interesting publication. Came out in 2010. Yes. Then of course there's this IMOW and the user manual, which is remarkable. I think sometime Usha must explain the whole thing if she can share with a larger group, because that means she would do the right thing. But it's really something very beautiful, as Andrew said. It was very simple. Initial part of it was the adapted LTPC, which means all we did was the SPRUC, we just cut them into strips, and therefore we were able to do developmental profile of a child, and then she expanded it, and then the team entirely in Canada worked on it professionally, and now we print it and we have stock of it, and now slowly we are selling. I mean, helping parents, not only those with disability, but those parents who are interested. Of course, then we indigenize a lot of our materials. Here I show you, just to show you this. This is what I call the South Indian look. Now you want to know what is this South Indian look, because then we did another lot of things which had the North Indian look. So we have the birth to 3, and the 3 to 6 is now being revised, and it's culturally sensitive. It can be used across, and so far it's in Tamil. Of course, we will do it. Yes, the next one, please. This is what we call the North Indian look. Now it's very interesting when you see the cards. And what is this? It's just every single picture of the Learning Through Play calendar has a flashcard. No words. We found words of all kinds. Words tend to stop the thinking. So it's very simple. I'll give you a very good example. You just take a whole lot of cards that show the father. You sit in the father's group and you distribute them. And you've got 30 fathers who keep saying the father is doing this, the father is doing that, the father is doing this, and father is doing that. Then you don't have to tell fathers what it is they can do in their own. It's sort of a self-learning tool. And then it's interesting to note that we think that it gives a message, but what the parents see in it has always been very positive, or it's something that they are seeing from a parenting eye, and that's made teaching through that very easy. Yes, sir. Just go ahead, next one. Then we brought out a toy manual, because the specialty of the toy manual is that parents are going to shops to buy toys. When I say toys, I mean, I would say learning materials, and they don't know what the developmental is for the child, what is good for the development. There could be others who cannot afford those toys. So we've also brought in how they can make it in the home. Yes, I think I'm almost through with that. Yeah. So the key learnings, and this is something very important, the universality and adaptability of the LTP across socio-economic groups. I've talked about rural, urban. We now have started going into the corporate world, and the affluent homes, and the problems of parents are just the same. Either one group has too much, or the other group has too little, but still the parenting. Simple, low literacy pictorial formats allow reach to even unlettered parents. The example Andrew gave you last evening about the mother in the tribal area was they wouldn't have understood any word of that Kannada, but they just looked at it and it made a lot of sense to them. The power of the pictures which parents in any setting can relate to. This is really something, and I can tell from, you can see the kind of wide expanse of experience. We've never had someone say, no, I don't think I understand what it says. They can draw even more beautiful meaning than what we think we. Now, the indigenized booklets and flashcards have replicated the original LTP visuals with cultural sensitivity to the Indian context. And I even went to the extent of saying North Indian and South Indian. Yes, okay. I think that's, yeah. Now, many innovative strides we have taken. We're very grateful for our partners in Toronto who've given us that freedom. And now we find that all these are it's just suddenly spreading to such an extent that I think we're not staffed enough for the kind of demands we're getting, but then we really look forward to, and you'll be very happy to know that starting 2022, Balamandir Research Foundation has finally decided to go into research. For a long time, we were a resource organization, a reach out organization, but now formal research is something that we're going to start with. And I think, yes, these are just pictures. Just take them 2 pictures for them to just understand how we looked at. Yeah, just take them through. There are just a few visuals, please. Yeah, now this is interesting. Where you had the snow, we put the sand, because none of the areas were able to work. Only in Kashmir we have snow. Now the idea was not snow. The idea was the child should play outside. And so those are the kinds of very interesting. It lends itself. That's what we said. Yes, please go ahead. I think there's just 2 or 3 more. Yes, and very important that here we did keep the father, but when we did change the gender of the parent, because gender is a very important area and we need more involvement of fathers. So this one is right. Yes, okay, go ahead. Thank you very much. I know there's so much more to share with all of you, but I'm sorry if I've overstepped my time a little bit, but Andrew, we can't hear you.
Maya, thank you so much. This was a wonderful presentation. And I'm so glad we've got this recorded because I think many people will want to go back over this and see whether there's things that you're doing that might be helpful to their work. And so this is good. I want to make a little quick point that when we took Learning Through Play to Maya and her team in South India, the concern was, well, is this something else the West is bringing to India? And Maya made it very clear that when she looked at the material, she said, actually, no, the West has taken things from the earlier Indian writings of Sanskrit, and
Yes.
they're just coming back to India. So that
Yeah.
made
If
that
it was from
problem.
the Vedic times,
Yeah,
early childhood was called lalavat.
yeah.
That was the way you parented the child. It is something that is something, yes.
So
It
we're
was
very
beautiful.
pleased
Yes.
that problem, in a sense, of where it's coming from, was dealt with, and it was very good of and gracious of Maya to point that out. Well, thank you again very much, Maya, and we'll we'll move now to the next presentation, and I think Professor Hussein will do the introduction to Tayaba.
Thank you, Andrew. Brilliant presentation, Maya. And
Thank you.
you're right about it needed more time. And I was speaking to Andrew yesterday that we would organize some workshops, and maybe just having a full workshop with you would be great. The other comment is that in England, we have set up a global center for research on mental health inequalities. And one of the important section of it is what we are calling reverse innovation. And there's so much of what you have presented today. I think we can learn so much and bring it to UK and possibly to Canada as well. So, many more discussions. So thank you very much for your presentation today.
Thank you, Mr. Thank you.
And our next speaker is Tayaba Karan. It's a pleasure to introduce Tayaba, who has, over the last very few years has developed into, I would say, a leading researcher in Pakistan. She is with PIL, and she is Assistant Director of Research and Development. She is an applicant on a number of very competitive grant applications, like the Medical Research Council of the UK, the Global Challenges Research Fund, Grand Challenges Canada, and the Higher Education Commission of Pakistan. And one of her main areas is around parenting. She leads on the division of mood disorders. She is a master trainer on learning through play, which has been integrated with different interventions. And it has really, with her leadership, not only expanded across Pakistan, but she is supporting outside Pakistan as well, as Kumran mentioned yesterday. So up to you, Tayaba.
Many thanks, Prof. Thank you, Andrew. Hi, everyone. Yesterday, Professor Naseem has shared our journey of learning through play, starting from feasibility testing to implementation and then scaling up, transition to scaling up. Today, I would be talking about our efforts towards improving access to this integrated parenting intervention, low-cost intervention using digital solutions. Next slide, please. We have heard from both from Professor Naseem and Professor Bhutta regarding the need for developing, refining, and testing these interventions. We all know that rates of depression are high. If we talk about maternal depression, 1 in 4 women experience antepartum depression, and rates are, and 1 in 5 women experience postpartum depression. If we talk about Pakistan, the rates are even higher, like between 23 to 35% women experience maternal depression. Next slide, please. Despite this prevalence and huge economic burden caused by these postnatal mental health problems, the treatment gap is huge, both in high-income countries and in low and middle-income countries. A recent report by Professor Atif Rahman has highlighted that the treatment gap for postnatal depression in Pakistan is more than 90%. Next slide, please. So it is very important to understand the reasons contributing to this growing treatment gap in maternal mental health. And reports, the published reports suggest that the reasons and barriers are quite complex, and they occur at multiple time points in pathway to care. It can be at patient or individual level, like in terms of lack of education, lack of awareness about postnatal mental health problems. If we talk about our context in particular, women report that they are more preoccupied with domestic responsibilities. It is difficult for them to travel to the intervention sites to access these available treatments. If we talk about partners and family members, they somehow tend to normalize the symptoms that are experienced by these women during postnatal years. If we talk about healthcare professionals, the published literature says that health professionals perceive them as not well trained to deliver mental health services. Then another level where these barriers frequently occur, and that is very close to our culture, is socio-cultural level factors. A lot of stigma, shame, guilt is associated with mental health problems generally, and specifically if we talk about the postnatal mental health problems. Then organizational level factors, we always say that we always talk about the task shifting approach, but at the same time, we know that the midwives, the lady health workers, the traditional birth attendants always talk about, they are being already burned out with the existing role and responsibilities. So there are organization level factors as well. So, and if we talk about the structural level factors, again, there are a lot of problems related to pathway to care, health, lack of training and education opportunities for healthcare professionals. If we talk about the mental health training, so these are the barriers that occur at multiple time points during the care pathway for postnatal moms. Next slide, please. So considering all these barriers experienced by people in different contexts, the question is the digital mental health an answer to this global mental health crisis? And I found this useful quote by Prime Minister of Canada in a published paper, saying that if we can use this technology to order food and to interact with people, why can't we use this to make ourselves and other people healthy? Next slide, please. Now, I will be talking about the two main projects that we did as part of the Roshni project that Professor Naseem has mentioned yesterday. So if we look at the recent telecom indicators, these are quite, this show a very hopeful picture, because the teledensity in Pakistan is quite high, and the penetration of internet usage is also quite promising. Like more than 50% of the population have access to, and more than 87% population have access to cellular or landline phones. Next slide, please. The first project I will be talking about is development and assessment of a mobile phone application that we developed using this integrated learning through play plus intervention for depressed moms. Next slide, please. For this project, we recruited mothers from 3 large cities across Pakistan: Karachi, Lahore, Rawalpindi. We recruited and randomized 208 depressed mothers of young children. We assessed, we screened these mothers using EPDS, and these mothers were assessed at at baseline and then 3 and 6 months using primary outcome measure, which was patient health questionnaire to assess the severity of depression. And there were few secondary outcome measures as well that included assessment for anxiety, their health-related quality of life, and improvement in their knowledge, attitude, and practices for child development. Next slide, please. So I will take you through this Tech Mother Care. This is the name for the application that we developed using Learning Through Play Plus. It has 4 different components. The first important component was momentary assessment. So this application was developed through involvement of our patient and public involvement group. And initially the idea was to use all the 10 items of EPDS for this momentary assessment. But when we pilot tested that, most of the women said that these are, receiving all 10 symptoms each day was perceived as quite intrusive. So through our advisory group, we decided to assess 4 core symptoms from EPDS. One was about depression. Second question was about anxiety. Third was about the suicidal ideation and self-harming behaviors. And the fourth question was about the sleep disturbance. So these questions were, all these questions and the intervention was in Urdu, and an alarm was triggered on their on participants' mobile phone, and through that alarm, they were informed that they have a new message in their app, and they are supposed to respond to that message. So this was the momentary assessment of their mood and mood-related symptoms. Next slide, please. Then there was a component of generic text messages. So this was about receiving 2 standard messages, one from the Learning Through Play, and the second one from Thinking Healthy program, that was the plus component. All the women who were part of this intervention arm received these standard messages, 2 messages each day for 3 months. Next slide, please. The innovative part within this Tech Mother Care intervention was the intelligent real-time therapy. So these were the specific messages that were contingent on participants' response to those 4 items that I mentioned earlier. That was part of the momentary assessment. And depending on their response to the question, they were provided with the different strategies. Like if they responded yes to item related to depression, they received some distraction techniques. If they responded yes to item on anxiety, they were provided with a detailed description of how to do the deep breathing exercise. And if they reported yes to item related to sleep disturbance, they received some guidance related to sleep hygiene. So this was the intelligent real-time therapy that was not given to all the participants in the intervention, but that was contingent on their response to momentary assessment. Next slide, please. Since we were working with depressed mothers, so this was quite vulnerable population. One point that I want to highlight here is at the time of screening, we already excluded the high risk group, those who scored 3 on item related to suicidal ideation on EPDS, and we excluded those potential participants from the trial, but we referred them to the nearby psychiatric hospital for their further evaluation and then treatment by the treating psychiatrist from those units. So there was a crisis plan embedded within this Tech Mother Care application, and through this plan, this message was with participant consent was sent to a relative or a friend as well, and they were informed to take the participant to a nearby psychiatric facility just to highlight the risk. Next slide, please. So next slide, please. we did some qualitative work as well, both before the intervention and after the intervention. The qualitative work before the intervention informed that participants prefer to receive both the text messages and the pictures as well, just to make the text messages more clear for them. They suggested to add a component that should help them to improve their interpersonal communication and relationships, and they wanted to have this intervention in Urdu. Next slide, please. If we look at the quantitative results, we can see that both the groups, like both those who were participants who were in the control arm and those who were in the Tech Mother Care arm, for both of them, the scores improved from baseline to follow-up 1 and follow-up 2, and we can't see statistical difference between the two groups on any of the outcome. Next slide, please. However, through our process evaluation and qualitative work, participants talked about how they perceived this intervention. For them, the intervention was quite easy. The messages were easy to read and comprehend. They feel supported. They felt good about after receiving the intervention, and they felt that they are now better able to manage their routine after being part of this intervention. So there was positive feedback about the intervention in qualitative interviews. Next slide, please. They also highlighted some challenges, like there were participants who said that the breathing exercise was quite helpful, but for them, they said that it was difficult to understand the procedure involved in breathing exercise just by reading the exercise. They suggested to add components related to diet and nutrition that would further help their children's health and well-being. Next slide. That's all about Tech Mother Care. The second project was about delivering the intervention LTP through telephone. For this project, the plus component was different. I will talk about the plus component in detail in next slide. Next slide, please. Again, this was a multi-center trial. We recruited and randomized 370 depressed mothers of young children. One of the inclusion criteria for the participant was they should be able to access, they should have an access to mobile phone for at least an hour per week. All the participants were assessed for their health and well-being at baseline 3 and 6 months after randomization. Next slide, please. So this LTP Plus was delivered in 10 sessions over 3 months. First 2 sessions were the sessions in first 2 months were weekly and then fortnightly, and each session that was delivered over a telephone call lasted for 50 to 60 minutes. Learning through play was the same that we have already talked about. The plus component was the interpersonal psychotherapy. It talked about the role transition, because at times it is very difficult for women to understand the positive aspects of this new role, as they are more preoccupied with them being overburdened with the new responsibilities. So it was important to talk to them about the positive aspects that are associated with their new role. Then how to resolve the disputes and manage their disagreement. Communication analysis was very important. This was the need that was highlighted from a lot of our qualitative work. So a communication analysis was done through role plays in different sessions. Then there were some sessions that were specifically targeted on problem solving. So this was the plus component in this telephone delivered intervention. If we look at the results related to maternal health outcomes, we can see that those who were in the intervention arm had significantly significant difference from those who were in the control arm at 3 months in depression, anxiety, all 4 domains of WHO quality of life, and this effect was sustained at 6 months as well. Next slide, please. Since this was the plus component has a lot of interpersonal stuff, so we made sure to include some outcome measures that would tap into this interpersonal related aspects. So on postnatal bonding questionnaire, this is the questionnaire that assesses the level of psychological burden of parenting experienced by these mothers. So we can clearly see this. Those who were in control arm had a higher score in this psychological burden as compared to those who were in the intervention arm. And again, the effect was sustained at 6 months. Then experiences in close relationship. This assesses the attachment style. It can be an anxiety related attachment style or attachment related avoidance style. Then if we look at the dyadic adjustment, the difference between the two groups was again significant. It was improved for the participants who were in the intervention arm. Next slide, please. Maya has beautifully talked about the importance of informed parents as a right of every child, and for a mother to be informed about child development. So if we look at the results, those who were intervention arm had significant improvement on their CAP scores. This CAP scale was adapted from the learning through play intervention. Next slide, please. I would briefly talk about some qualitative findings as well. We have a lot of verbatims in our qualitative work related to the perceived impact of this telephone delivered intervention. I have shared 3 different quotes highlighting the improvement in 3 different areas. Like they appreciated the fact that now they are better able to communicate with their partner, because before they used to argue over small things. Then they said that they now know that each child has a different personality and they have different needs as per their personality. So they are now more frequently take their child to a nearby park or shop. They said that their communication skills have not been improved and they try to say their point of view without being aggressive. Next slide, please. They also talked about, this different mode of delivery, and they said that receiving the intervention over telephone has helped them to overcome the problem of getting confused and anxious while talking in a face-to-face meeting. This saves their time that is required for traveling to the intervention site. But one participant has also said that at times people are more comfortable in face-to-face meeting, and they have a better focus in a face-to-face meeting rather than a telephone delivered intervention. So this is the overall feedback from these qualitative interviews. That's all from me. Thank you.
Thank you very much, Tayyaba. Excellent presentation. I think we do not have time for questions right now. I think there are some in the chat, if you are able to respond to those. Otherwise, maybe we can look at it towards the end. Yes, Andrew.
I noticed that Anne from ADRA is interested in connecting with Maya. So I think the way to do that is through Rabia. So anyone who wants to connect at this point until we get a better system in place, just give Rabia a note and she'll connect you. Okay,
could I just respond to that, Andrew? I just want to say I also that people want our materials and all. I think if Rabia can just get all that together, we'd be most happy to share. We're very happy to share every single thing that we have done, because I think in sharing is what I think LTP must grow and you can learn. So everything we are ready to share. So just Rabia, will you just be the host box and the person for us? Thank you.
Brilliant, Maya.
Thank you, Maya.
Yeah.
Okay, Nusrat, you'll introduce the next guest.
Yeah, it's my pleasure to introduce Madhurima Saha here, who I have recently started to work with regard to LTP in Bangladesh. Do we have Madhurima in the audience? Has she joined?
We need to check.
Yes,
She was.
thank you. Yeah, I have joined.
Okay, okay,
you.
Madhurima, brilliant. So Madhurima is an MHPSS coordinator with the Health Department of Save the Children in Bangladesh. She is also with the Department of Clinical Psychology at the University of Dhaka. She is, like I mentioned, over the last few months, have started to look at if learning through play could be introduced in Bangladesh. It would be at Cox's Bazar in collaboration with Save the Children UK and the Manchester Global Foundation. Her interests are around development psychology, maternal mental health, and community psychology. So Madhurima, to you.
Thank you very much for this nice introduction. So here I am presenting my, actually I cannot switch on my video because my internet connection is very poor. So I'm just presenting. Let me try one. Okay, can you see me?
Yeah, we
Might not. Okay. Okay, so actually, as we all know that Learning Through Play is a parenting, group-based parenting program, and we are also trying to integrate that is integrated in the Thinking Healthy program of WHO is integrated here. And the NECC team of Philippine Cox's Bazar was the first to initiate this implementation of LTP Plus in the Rohingya mothers who have young children, and also we have our esteemed technical supervision and guidelines from SMC in the UK and ITV, Manchester Global Foundation, and Pakistan Institute of Living and Learning. So it is a collaborative approach to work or to implement LTP Plus with the Rohingya mothers who have young children. Next slide, please. Next slide, please. Okay. So the objectives of this, there are multiple objectives here, but the primary objective is to see or evaluate the clinical and cost effectiveness of LTP Plus integrated parenting intervention in reducing depression in the mothers. Sorry, maybe I have missed one slide before. Go back. Okay, yeah. As we all might know that since 2017, around over 800,000 Rohingya people, including women, children, and also people with disabilities and aged individuals, have traveled all the way from Myanmar to Bangladesh, specifically Cox's Bazar, who have experienced severe actual violence, trauma, and loss and separation. And currently, the number is it's raised over 900,000, and we have 52% of them are women and 23% of them are in the reproductive age. And according to the recent report of UNHCR, actually those people, those women particularly, and due to their chronic exposure to violence and chronic stress, their mental health and maternal mental health have significantly compromised. And it can have a detrimental effect on the development of their children, particularly the physical and mental development, and also the bonding between child and parent. So this is a very sensitive population to work with, because this population have experienced severe trauma before. And also currently, they are not in a very good position because they have to compromise every day with their day-to-day life going, because the things they receive are not sufficient for them. So they are all, most of the women, I would like to say, are still in severe problem and trauma and stress as well. So here, one primary question to ask is, can LTP Plus be an effective and mainstream intervention to improve mental health and child health and development outcomes in such traumatized population here? Next slide, please. Okay, so the primary objective of this project is to evaluate the clinical and cost effectiveness of HP Plus parenting program in reducing depression among the mothers with young children whose age would be from 0 to 1 year. And there are other secondary objectives like to reduce anxiety and parental stress in mothers, and also improve their health-related quality of life, pursue social support, maternal knowledge and practice and about child development, and also implementing child health, nutrition, and developmental measures. Next slide, please. Actually, while starting this project, we had a couple of difficulties. That's why this project is still ongoing. We are also progressing, but there are some challenges there because it's a risk-based intervention. But during the beginning of the project, there was the COVID breakdown here. And at that point of time, in this camp context, group gathering was strictly prohibited. And also all other essential service was, only the essential service would go with the flow, but other service was prohibited. And it's actually one kind of tragedy here that mental health service was not considered as the essential service there, because only health service was one, health and sanitation service, but any future service was not allowed there during this breakdown. So we had to take permission a lot of times. And there are other problems here. For example, the challenge of stigmatization. Mental health in this population is still very sensitive issue, and especially for the mothers, for the people, for the women who have children, young children. If there is a thing that they are being, in a group intervention, and if someone there's a possibility that there might be a rumor that those people's mothers have severe mental problems or issues, that stigma can affect those participants and also their families. So actually, that's why our sample size was very lower, and we need to screen them with properly, so that we need to create an awareness among the community before about this thing, that we are not dealing with severely mentally problematic person here. We're actually dealing with the normal individual. So for normal individual, we are actually helping them to reduce their problems and also have a good bonding with their children. So that is why our sample size here is actually 436 in total. There will be 2 arms. One is also routine care arm, and the other will be the intervention arm, as you might understand. So the routine care arm will receive the regular intervention that we as organizations are receiving and giving, and the other arm will receive the LTP plus intervention here. Next slide, please. Okay, so here is the process, the activities that we have planned. Actually, the LTP plus manual is not actually translated in Rohingya language, and also in other, and also there are some examples that we are afraid that this population might have understand properly, might have connect properly. We need to translate and contextualize the LTP manual to be appropriate in this for this population actually. So for this reason, we need a consultant, and we are actually in the hiring process of this consultant. And then we after the thing is done, after we have a contextualized LTP manual, our psychologists and the community health workers will be trained properly on this manual. And then the parties, we have to recruit participants, and we have to randomly assign them to 2 groups. Actually, I just mentioned, one will be the intervention group, another will be the routine care group. And before the screening, we have to make sure that they give their informed consent properly. So in the consent form will also be in the language. And we have to also make sure that if there is someone who is severe depression and severe psychological problems, we would like to refer them for higher mental health support to other organizations, and they will not be included in this project actually. After that, we have a baseline measure, and then after the intervention is started, we will have after 3 and 6 months of the intervention, we will have other measures. Here, I would like to mention that we are using a couple of measures like GAD-7, CHP-9, and MSPSS, multi-dimensional social support scale. So these are the things we are using, and also CAP. We are using CAP, and in order to measure the cost effectiveness, we are using the client service receipt inventory. So these are the scale we are using, and we will be using it. We will be taking the measures after 3 and 6 months. After that, after the analysis is done, we will try to share this. If we find, I'm hoping that we will find that this is effective for this population, and we will have a data on it, and we will have a proper proof that it's effective. We will try to analyze it and scale this up. We will try to actually work with bigger population and bigger groups in this context. And after that, I am hoping that this LTP Plus will be actually implemented in other parts of Bangladesh as well. Next slide, please. Okay, so I already mentioned that we are expecting that the maternal depression and is reduced, would be reduced after they have this intervention, and is effective, accessible, and scalable, cost-effective program would be there for the Rohingya mothers. And also, it will, in turn, I'm hoping that it will improve the child's health as well, child's mental and physical health as well. And this scalable evidence-based model would be replicated in other parts and hospital settings in Bangladesh, in other parts of Bangladesh as well. And I'm hoping that in other organizations who have primary healthcare center and immediate support in the community, we can actually work with them also to actually speed this thing up. Next slide. Actually, that is all from me. And this project is actually in a state that we are actually starting up. We're actually hiring the consultant, and the consultant will be on board very soon, I'm hoping. And when the consultation is done, when we have a contextualized LTP manual, we will be having the training, and this I'm hoping that this thing will start on field very soon.
Thank you. Thank you very much, Madhurima. Excellent presentation. Again, we do not have time for questions. Please put your questions in the chat. Andrew, handing over to you for the next introduction.
Yes, I am. Thank you very much, Dr. Ayub, for your presentation. I look forward to the results and how this goes along. Sounds like a very important program. Our next speaker is Dr. Dong Jidong. He's a senior lecturer in psychology at Nottingham Trent University, UK. He completed his PhD in psychology at the University of East London, funded by the university's excellent PhD studentship. His PhD research also received accolades such as the 2017 and 2018 Delegates' Choice poster winner at the British Psychological Society annual conferences in Brighton and Nottingham, UK. Dr. Jidong is currently leading numerous evidence-based research interventions in culturally appropriate mental health for African and Caribbean communities. We're delighted to have you with us. Welcome, Dr. Jidong.
Thank you so much, Andrew, for that brilliant introduction. And good afternoon, good morning, good evening, depending on what location you are at the minute. Thank you once again for this opportunity to speak with you or give you some kind of an overview of the works we've done and what we're going to be doing in the next couple of years within or around maternal mental health, especially in Nigeria and Kenya. So within this presentation, I will give you, I'll talk you through briefly around some of our published work, and of course, give you some overview of the trajectory of the work that we are going to be doing going forward within the maternal mental health. Next slide, please. So I wouldn't want to repeat myself all over again. We've heard from numerous presenters and speakers who talked about how devastating it is around maternal distress and how these have potential intergenerational impact on the child and well-being, and some of those has actually re-informed us of the fact that if we really want to have a brilliant future, then the children of today have to be taken care of, and which is one of the core theme of today's conference. So one of the things I would like to kind of throw out there for everyone on this call is, if you have a kind of a magic wand and you are asked to call on one thing that can bring about healing, or perhaps reduce the pandemic, if we like to call it, in maternal mental health, what could that be? I believe we may have different delegates having different perspectives, but if you see across the two countries we're looking at in this presentation, that is Nigeria and Kenya, one of the things that have really stood out is around poverty. So poverty is sort of linked, to different aspects of our maternal mental health. And if you look at these countries, are obviously developing country, or what you want to call a third world country, and poverty, it's almost at the peak. And this is affecting significantly maternal mental health, and of course, the health and well-being of the children who are the future leaders of tomorrow. Now, about 20 to 30% of mothers in Nigeria suffer from postnatal depression. And most of this is only 1 out of 5 moms who are suffering with any form of mental health distress that actually have access to some sort of support or care. So you could see that it's a big problem that we'll have to deal with. And similarly, you could see the level of infant mortality rates and deaths of children under the age of 5 in Kenya is just staggering statistics. And you'll be wondering that all these are happening in the modern day 21st century that we are living in. And of course, we know that this is even more challenging in few of these, or most of these communities in Nigeria and Kenya. There might be skirmishes of mental health care in one community or the other, but these are usually within the urban areas. Then how about those living in the rural areas where there is a staggering level of poverty and very limited access to care whatsoever? So in that case, you could say that the LTP plus learning through play, it's becoming very useful, because obviously this is involve low literacy. And of course, it's also cost effective, as we've seen in previous other study. So in the next couple of slides, I'll guide us through some of the papers and the research we've conducted in Nigeria and in Kenya. So first of which, thank you. The first of which is a systematic review we conducted on maternal mental health and child well-being. And this also constituted part of our preliminary works or foundational research that we started doing, and trying to dig deep into existing literature to see what has been done previously around maternal mental health, how has this been, play out, and perhaps what can we learn in terms of culturally readapting the learning through play or other forms of mental health intervention for this community. And in this case, we obviously or we are aware of the fact that maternal mental health distress has, it's a kind of a disease burden, and of course it has severe impact on the mom and that of the child. So in this systematic review, what we did was to then, first of all, we adopted the PICO model, which is the population phenomenon of interest and context. So this sort of helped us to formulate the review strategy, and by doing so, we also use the Boolean operators, which kind of strengthen the rigor in exploring and maximizing the different databases that we're researching on, and these were including PubMed, Scopus, ProQuest, etc. Now, we were targeting research that we published within a 20-year span, that is between 1999 to 2019. Now, in this systematic review, we had about 34 studies which met the inclusion criteria for the study. And one of the things that stood out, or some of the themes that emerged from this after a qualitatively synthesizing and analyzing those studies thematically, is that marital difficulties were one of those key sources of mental health distress among women in Nigerian community. And for example, some of you might be aware that there is such a high level of cultural demands on moms, not only taking care of the young ones, but also have to fend for the family, involved in all sort of trade and farming. And in some culture, Nigerian cultural practices, the men are likely to be passive and not necessarily given so much support. Another thing as well is relationship status of the mom. Now, in this case, because of the religious connotation of the Nigerian cultural context, some kind of biblical and perhaps Quranic inscription, it is seen that it's often less of a woman to have a child and not being married. So all these are sorts of mental health distress. And then the gender of the child also stood out among the papers that met the inclusion criteria. In this case, there is this high emphasis on the male child, within the Nigerian context, and likely to relegate the female children. And then mode of delivery. Now, one other aspect of the findings, which again, stood out, was around a significant emphasis for women who have only male children are likely to, face all sorts of challenges from their maternal, paternal homes, and even sometimes threatening the marriage and so on and so forth. Now, within this systematic review, we have to then begin to draw some conclusion. And of course, we noticed that there was, again, high level of paucity in evidence-based support for moms. Most of those research were likely to be around, the frequencies of this mental health distress and that sort of studies, or in only few of them which have pre and post measure of observing some kind of intervention. So obviously this then left us with the recommendation for producing some kind of, or offering some kind of randomized controlled trial to see how these cultural practices and values can be integrated to offer a solution for this community. Next slide, please. Right, so this is another study, again, in Nigeria. We did focus groups. In these focus groups, we had about 40 moms who participated in the focus group. And in each of those focus group, we have moms between the 8 to 11 persons per group, and they all had children between the ages of 3 to 48 months. For this focus group, each of it lasted approximately 60 minutes. And of course, it was audio recorded and transcribed verbatim. So we adopted IPA, interpretative phenomenological analysis, because we're particularly keen to observing or understanding how some of these lived experiences of moms have impacted their mental health in one way or the other. And again, this also constitutes a significant part of our introductory studies to understand and dig deeper into what some of the trends of things or challenges and circumstances affecting moms in Nigeria. And that way we'll be able to build more understanding, and that can be transferable into any potential intervention we'll be offering on a later date. In this focus group, we had 3 key themes emerge, which are the primary findings. This involve the experiences of persistent psychological distress from the time of childbirth. So this has something we might want to call child or birth trauma. Some of the women underwent cesarean operation, so they are likely to still be experiencing some kind of realistic flashbacks of how dreadful that is, coupled with the low level of technology and medical equipment for this kind of operations in Nigeria. Another theme was cultural practices that influence feelings. So some moms have the opportunity of having their own mom, which is the grandmother of the child, to support them during childbirth, and while some don't. So those that usually don't have that kind of support also have another societal or community meaning in terms of something that has to do with self-blame or their low level of commitment or relationship or association with their family. Either it could be paternal or maternal. Now, the third theme was around anxiety that persists due to limited knowledge about childcare and perhaps also access to support and healthy food. Again, if you remember in our introductory slide, I did mention about, if at all, I have one magic one, that is obviously going to be how poverty can be eradicated or removed. And we believe that if that is addressed, then we are likely to see a significant change in terms of mental health outcome or maternal mental health outcome. So again, we understood that research, there is under research within this topic area. And some of the work we're actually doing, setting up the basis for other future research. Next slide, please. Thank you. So now we are looking at, we've just presented two studies that were conducted in Nigeria, and now is a study that we conducted in Kenya. Now, this is an LTP plus intervention, and it's actually, to the best of our knowledge, this was the first feasibility study that actually integrated parenting intervention for Kenyan mothers who were at the time suffering from postnatal depression. Now, the aim of the study, this feasibility, was basically to kind of test the acceptability of LTP plus, especially for these moms. So we recruited 17 mothers who had children between the ages of 0 to 36 months, and the moms themselves were within the ages of 18 and 45 years. Now, this was, in terms of design, this was a single and mixed method feasibility study. And of course, it took place in a low-income rural area of Fimbini village in Kilifi district of Kenya. I don't know if we have anyone from Kenya who is in this call might be able to relate or resonate with this community. So the moms were screened for depression using PHQ-9, that's a patient health questionnaire. And those who score 10 points and above were kind of further undergone interview using the CISR, that is the reverse clinical reviewing schedule, just to kind of like you want to call it, to double check the diagnosis of postnatal depression. So they will follow up at baseline and end of intervention at 3 months. So the moms also undergone interviews. Of the 17 moms, 12 undergone interviews. And these were analyzed using thematic analysis from a social constructionist theoretical lens. Now, in terms of findings from this paper, the intervention showed to be feasible and acceptable, with also a very high level of satisfaction among the participants. But of course, we are also talking about the results of this study with some levels of caution, because we only had 17 participants. And of course, this was a single arm. We didn't have a comparative group to double check the progression of the intervention. So, but again, from the qualitative arms of the findings, the study show that, or the women obviously perceive the fact that the intervention was beneficial in terms of reducing perceived symptoms of depression, the ability to cope with stress and other negative emotions. And of course, again, the statistics showed a reduction in PHQ-9, patient health questionnaire, and then the generalized anxiety depression scale. And of course, the study also showed an increase in the perceived social support, health-related quality of life, and also an increment in the improvement of mothers' knowledge about child development, and so on and so forth. Again, we understood because these participants were socioeconomically disadvantaged from low-income background. So the study showed that it's clinically effective and also cost-effective in terms of the intervention. Next slide, please. Right, thank you. This is another work we're doing in Nigeria, actually. This is around suicide and self-harm. This was a poster presented at the Sahar special event, the 24th of March in Manchester. And this work, we are basically conducting patient and public involvement event. And of course, we've had a few other presentations talking about PPI. And one of the key aim of doing this PPI for us was not to kind of imposing this intervention, LTP, and manual assisted brief psychological intervention for these refugee moms that have had history of suicide and self-harm, but rather to sit with them, discuss with them in a more conducive atmosphere, asking them what has been their experiences. These are the kind of offer we've got as academics, as researchers, but we don't want to impose it on them. We really want to consult with them, want to collaborate with them, also want to make it user-friendly, thereby they be part of the drivers directing how this intervention would be. So we target about 40 refugee moms, and then we had 4 PPI event, and so far we've collected significant information. We've made notes, and this is also helping us in working out the kind of modality and some of the best way in which we can adapt this intervention within the context of Nigeria, and which will best address the needs and the mental health challenges of this month. But most importantly, we are more keen to helping them or to involving them also have this intervention as part of they having a sense of ownership in terms of how this is being developed. And of course, we know that LTP is ecologically friendly. It's not just about the participants, but also them becoming ambassadors of this project, and also relating with others who might not have the privilege of participating even in the future intervention, and just cascading the impact across communities and across their networks. So our anticipated outcome for this PPI event was to kind of help us to evaluate and prioritize the areas of focus regarding the intervention. And of course, also have a kind of a continuous collaboration with these, persons that have participated in this PPI on each and every step of the way as we develop and build on this intervention. Next slide, please. So to kind of begin to conclude, and this is just to give you an overview of our numerous other research that we are working on. So far we've conducted 3 systematic reviews. We've conducted 2 focus groups study, and we have conducted 5 PPI events. We've done 4 of these in Nigeria. We've done 1 in the UK. And we've also done 1 participatory action research, primarily for kind of manual adaptation. So most of our activities now are on the second phase, which is we have about 3 studies that are being conducted in terms of feasibility and pilot trial. We have 1 conducted in Kenya, which I just presented. We have ongoing feasibility and pilot here in the UK, and we're also on the way to commence another feasibility or pilot in Nigeria. Of course, we have challenges of funding. And then obviously after now and the next couple of, in the nearest future, we're thinking about scaling up all this intervention using LTP plus and in some kind of cluster randomized control trials. Next slide, please. So I would like to extend our gratitude to all our supporters for all the research we're conducting at the minute. For example, Nottingham Trent University has been of immense support in terms of funding, and one of which is the Health and Wellbeing Strategic Funds, which is very supportive. We've also received good funding from the Global Challenges Research Fund, working with the University of Manchester. This has helped us to especially conduct the PPI event in Nigeria. And of course, we have received massive support from Manchester Global Foundation and the Pakistan Institute of Learning and Living in numerous ways that I will not be able to mention those because of time. And of course, I'm humbled and privileged that Professor Nusrat is here on the call as well, who is my mentor, who I believe all of this achievement were partly due to the mentorship that I've received from him. And I've also had an internal mentor at NTU, which is Professor Clifford Stevenson. So thank you all for listening, and I'm looking forward to any questions that you may have.
Thank you very, very much, Dong. We appreciate your presentations, very thorough. And I believe you will probably get a contact from Patricia Falope. She is working in Nigeria as well. And I know that I knew Nigerians want to stick together, you know, you got to work together. So thank you very much.
Thank you.
I don't think we'll take questions right now. What we'd like to do now is take a 15-minute break. And then when we come back, we're going to hear from Tajikistan, Dr. Nazarhudo Destembiev, and he's on the line now. He says his internet is not strong.
Hello.
But we'll welcome Nazar. We'll get what we can from him, and we're delighted that he's here. So we'll take a 15-minute break now, and then come back. So thank you all for today's presentation so far, and we're looking forward to the ones this afternoon.
Can we say exactly what time do you want us back? Is it 8:55 Canada time or?
Yes. 8:50 Toronto to Eastern time. I didn't say the time because there's about 6 different times, I think, or 7, I think. So
okay.
15 minutes, 12 to 15 minutes now. So just everyone run along and do what you need to do, and we'll see you back.
Okay. Thank you.
Thank you.
May I please stop recording?
Each time that Usha came to Tajikistan for training, they had a very clear outline of what they needed in order to expand, to continue to equip the staff and the people all through Tajikistan. It was a gradual growth throughout Tajikistan of the plan that they had in place. So Nazar, I get a sense that he has so many things that he works on, but he's got a great staff around him, and I'm glad to have him with us this morning. He's been working at Open Society Institutes in Tajikistan since 2003. He started as the regional director of Step by Step and Peaks program, and since 2010, he has been director of the education department. Nazar holds a PhD in social philosophy. He has also participated in various international courses and training. Since 2016, he is the Director of Education Programs, Art and Social Activism. So we're so happy to have you with us, Nazar, and it's over to you now.
Hello, everybody. Andrew, thank you very much for the wonderful presentation and introduction. Do you hear me, guys?
Yes, we do.
Super, super. I'm doing it from the phone, and although it is morning for you guys, it is almost evening for me in Tajikistan, in Dushanbe. And this is fascinating to be with you guys. But unfortunately, I missed the wonderful part of it of yesterday and today morning for me. But that was because we still celebrate the Victory Day on the 9th of May, and this is why it was a holiday for us, 9th and 10th. So not a big loss, huh? A celebration. But learning through play for me is like a heart in the programs of early childhood development in Tajikistan. And as Andrew mentioned, we've been working with Usha, wonderful Usha, we call her here, for the last 7 years in a row. Almost every year it was fascinating for us to have her with us here in Dushanbe, Tajikistan. And sometimes we have managed to travel for her in the north of the country and the south of the country to see people and children, those who are, we call, sorry to say, beneficiaries, direct beneficiaries. But these are something that we planned that we could have with Usha to work together and to understand the grassroots, what is happening there in the communities, because having her in Dushanbe all the time and training the people who are coming from these places but not seeing these places, we thought that would something change in a row of trainings and interactions all happen here in Tajikistan. So we were lucky to have her with us, and we were lucky to have the funds from the Open Society Institutes. Globally, it is Open Society Foundation, but here locally, we call it Open Society Institute. So if we go to first slide, rather than the introduction, seeing my name, yeah, so what do we wanted to achieve is basically, this is something that looking at the system-wise, what do we have in the system and what can elaborate more on what is going on with different players in a row, like UNICEF, Aga Khan Foundation, World Bank doing something in early childhood education. But what we do is to help actually pedagogical and psychological field, but particularly with the focus to parents and their involvement in the family. So we thought that it's good that big donors and government is focusing on pedagogical and psychological aspect of it, but through the learning through play, we wanted parents to be very involved, because we thought that, and we are thinking and we believe that parents are the most sort of in need and also powerful tool for us. Sorry to say tool, but this is, you understand what I mean here. And also with this spectrum, we wanted to work with children directly. The moment we have parents with us in the room, parents with us in the system, this is very easy for us to reach the children, because sometimes and often it is very complicated to just focus on pedagogy and psychology of the whole trend. But then using parents in these two spectrums is very useful for us, and we actually love working with parents. And every time Usha is here, we organize meeting with parents and going to the families. So yeah, the center-based activities like in the kindergarten or community-based centers, these are very good ideas, but the thing is that we wanted to reach to the families and organize these family-rich programs, very short ones, but very wise, in place in order to reach the children and also to change the whole culture of visiting the homes and the families at the community level, because so far it is almost a taboo not going to the families and not using the community as a platform for learning and exchanging. Can I have the second slide, please? So, as I said, working with this year was last year, like 2021, after this COVID-19 sort of loosening the trends here. And we started to communicate with Dushanbe city, because Dushanbe city is a capital of the city of the country. It was complicated to work because of the bureaucracy and of course the system. Even though it is the capital, but the system was a bit sort of reluctant to any kinds of innovation, and particularly in the early childhood development field. So we started to negotiate with Ministry of Education and Science and the city mayor, office of the city mayor, to work with educators and leaders and psychologists from the new kindergartens that never been enrolled in the step-by-step program or some other learning interactive learning programs that were introduced by UNICEF or Save the Children in the past, or the Aga Khan Foundation. So it was totally a new area for us. And of course, the materials that we translated into Tajik are very sort of easy to understand. Every time Usha is here, we work with calendars and see and hear from the practical point of view what is important to be there, what is important to be changed, what are the terminologies that we need to use using these practitioners from the kindergartens and community-based centers, and also parents. So these trends were important for us in order to understand more in depth what is going on there, what do we need to bring as a new expertise. So, and the number that you see, the preschool teachers and educators, specialists, we've involved last year from several series of trainings on calendar and some other materials that would exist from the step-by-step point of view that we used for the last 20 years in the country. And there are similarities, of course, of the elements of usage of these materials. And we thought that it would be good sort of to combine and see what we have in the end as a product. So, and also, as you can see, there is a private kindergarten that this is the first time that we managed to involve, because usually it is very complicated to mobilize the educators from the private kindergartens, because they are sort of closed societies. They are reluctant to any kind of trainings also themselves, but also from B point of view, it's the system that is reluctant to involve those. So we started to work between these two reluctance from A to B. And when last time Usha was here 2 or 3 years ago, we decided that we would involve those private kindergarten teachers. That was the plan from the very beginning, but because of the breakout of the COVID-19, that was complicated to conduct any trainings with the teachers or with people in the room. So this was complicated for us. But then last year, we managed to do that, and we brought some specialists from the private kindergarten, and it was sort of a revolutionary for them to open the eyes and then bring the platform of exchange and learning from each other that was a sort of fascinating, and they loved the learning through play materials, particularly the calendar. And can I have the next slide, please? I think this is going to be the last one, and then we can talk. Yeah. So even though it was a year of intervention from the COVID-19 outbreak, it was important for us to see how do they use the materials. And during the monitorings and mentoring, we have a system in place that every training is accompanied by a monitoring visit in the place, and also mentoring with those who have been working with USHA since 2012, 13. Here locally, we've called them parent facilitators, and we use them as resources. And they are from different parts of the country. And then, fortunately for us, 3 of them we have from Dushanbe and district of subordinate areas. So we've involved them for the monitoring and mentoring process, and they did a very good job to work with the teachers on the calendars. And also one of the aspect was home visiting program. And they did this, and it worked very well. During this short period of time, 2-3 of them actually got the prizes in the competition that they call Educator of the Year. And you can see this slide. They have actually participated in this competition, and before the participation, they officially wrote a letter if we could allow them to use the learning through play material for this competition. And we said, this is all yours. So you can use it as a methodology, you can use it as a content-wise. But the important thing is that you work with the parent facilitator who is appointed and as a focal person. And they did this job, and 2 of them got the first and second prize even in the competition. And that was one of the area that the city, the mayor of the city, those who are in, the mayor of the city, office of the mayor of the city, those who are in charge of education, they wanted to know more about the materials. And we are going to have another series of training this year in the summer break, and also in the fall, with those parent facilitators. And we will bring this again to Andrew and Usha, and if it is possible at all, to have Usha with us as a follow-up visit this year after this COVID-19. I think this is something that we will raise separately in the private conversation with Andrew and Usha, and see what we can do in that direction. So I think this is something for the very short time being at this moment. But I think that this is a fascinating process for us to see this new area, new places to go and explore, and new faces, of course. And we're looking forward to do this work more with parent facilitators. And it would be good to still keep this relationship, professional relationship with the center, as we call it here. And I think that there is something that we can do together in order to do and bring some changes that children need, particularly now that in this world is rapidly changing, and the changes are tremendous, particularly with working with parents and families, especially now that some kind of techniques are needed. So maybe online, sort of at some places that internet can allow, we can do some kind of online courses, short online courses, not maybe for an hour of intervention, but at least 20, 25 minutes online short courses for parents get them together and do something online, not waiting for the in-person activities. I think these are ideas, and we will put them in place so that we can exchange with Andrew, Usha, and whoever is in charge now, and then we will see what we can do in that direction. I think I will stop here, and we will see if in the end of all presentations, if there's going to be questions or any kind of suggestion, we would welcome everything. And thank you very much for having me today, speaking to you guys. And this is, as I said, fascinating, wonderful moment, and both learning and exchange, sharing, of course. Thank you very much.
Well, thank you so much, Nizar. I'm so glad that you're able to be with us and your internet worked so we could hear from you. Lovely presentation. And my sense is that, and you may not have heard this earlier, but there are other groups that are working very hard at trying to figure out how to get through to parents, relate to parents using the technologies that we have available, partly because of COVID and partly because maybe we can reach more people. It may be a supplementary kind of way of doing it because face-to-face is not feasible all the time. So it's, I think you'll find lots of other colleagues in this work and parenting work and learning through play work that are interested in chatting about that. And I think that at the end of our session today, Nusrat and I will have just a bit of a conversation about some follow-up, possibly getting together quarterly for various topics of discussion, and this may be one of them, of using technology to assist us in our work. So thank you again, Nizar, and delighted to hear from you. Yeah, very good. We're happy to have Dr. Torella Ike with us today. I just want to make sure that she's here. Yes,
please.
Okay,
here.
Wonderful. Okay. So Dr. Torella Ike is a lecturer at Teesside University, UK. Torella's research interest revolves around maternal mental health and well-being of women and children from Africa and Caribbean communities. Torella is also actively involved in the delivery of an ongoing trial using LTP plus CACBT. Now I'm going to say that again because these letters, are getting long. Once you start adding plus, so it's LTP CACBT. And I hope Torella can tell us exactly what that is. I have a guess of what it is, but we'll leave that mystery to you. For mothers of African and Caribbean identified descent in the UK. Torella, we're very happy to have you with us this morning, and it's over to you.
Wow, thank you so much, Andrew. Sorry, I have to put the camera off just to allow the bandwidth to be more accommodating. Yes. Okay, so the CACBT, or the LTP plus CACBT, it refers to learning through play plus culturally adapted cognitive behavioral therapy. Okay, so I will be presenting on the topic on online learning through play as it applies to the context of treating depression here in the UK for African and Caribbean mothers. So I'm presenting on behalf of my team. So Dr. Dong Jidong, I've previously talked about, set the context of this broader research, but I'll be specifically focusing more on the context of the UK. And also as part of the team is Professor Nusrat, as well as other team members who I would definitely acknowledge during the course of this project. So essentially, it's a work in progress because we've started the trial. So again, just a brief background of the context. It's well established that by 2030, an estimated depression will be the leading cause of the global disease burden. Sorry, please, if you go to the next slide. Thank you. And approximately 75% of women would suffer from it as a result of parenting and childbirth, which could be a very challenging times for these mothers. Again, if we think about the context of depression, especially for people of color from the African and Caribbean community, they stand a higher risk of it, especially as it relates to, for example, here in the UK, the high level of single parenting. Again, there are other explanations that sort of explain why single parenting is quite common. For example, issues of cultural values, issues of increasing crime rates from the male perspective does have an impact on the high level of single parenting. And then there is also the issue of low service uptake of mental health care, which is another aspect. And again, this ties down to cultural stigma as well, because within the African culture, there is this perceived sense that issues of mental health are not something to be talked about. In fact, it is frowned upon. And during the course of the trial, some of the things that were coming up from the moms were like, I could not openly talk about my emotions because I'll be looked at as a lesser woman, not able to deal with her emotions. So again, that low service uptake is something that is quite prevalent amongst moms from the African and Caribbean community. And then there is also the issue of lack of culturally appropriate care. That is a care that appears not to take into context the cultural sensitivity of those that are pretty much involved in the specific situation. So for example, the perceived tendency to over-medicalize mental health issues as something that is again, needing to be treated in that specific way without actually taking into context the different cultural variations across board. And then within the context of the UK, there is also the issue of the fact that most people from the African and Caribbean community tends to be socially and economically disadvantaged. Again, if we look at the statistics of dropout of school, it's more likely to affect those from the African and Caribbean community when compared to their white counterparts. And again, they also tend to be at the very bottom end of the scale, especially as it relates to low income. So if you recall, during the pandemic, people from the African and Caribbean community suffered more in terms of the high death rate when compared to, especially from the health sector, when compared to the white counterparts. So all of this does have an impact on the issue of maternal mental health here in the UK. I've talked about the dropout. Next slide, please. Okay, so the key aims of our research was quite multifaceted. So first, we came to test our research protocol in terms of how practicable or feasible will it be for us to carry out a future fully powered trial. See, for example, issues of the estimated sample size and the cultural appropriateness of the learning through play plus culturally adapted cognitive behavioral therapy for mothers from the African and Caribbean community. And we were also keen to test the randomization procedures. So for example, if we were to compare the LTP plus CACBT with psychoeducation, what, for example, is the level of retention? What is the feasibility of the acceptability of the intervention? And what are some of the things that we could learn from the entire process that could, for example, avoid anticipated pitfalls or things that could hinder a future large-scale trial? So for us, we're keen about for example, the worthiness and viability of the intervention for scale up, as well as the fidelity of the LTP plus CACBT intervention for mom from the African and Caribbean descent. So essentially, this work was pretty much building on a previous systematic review that we've done in the past, which Dr. Dongido spoke about, as well as a previous paper where we sort of look at the experiences of mom from the African and Caribbean community as it relates to issues of mental health. So we're keen to sort of integrate some of those findings plus testing the intervention to see its feasibility as well as worthiness for a future scale up. Next, please. So in terms of the theoretical framework, again, our study was underpinned by the Bowlby's theory of attachment, as well as Piaget's theory of cognitive development. So I'm not going to be talking about that because our previous speaker yesterday really did a substantive justice to that. So Rabia, for example, did explore that in much more depth. So I would just go through the aspect of theory of change, which we're trying to use to sort of underpin whether or not the LTP plus could be able to be used to test the theory of change in terms of that wider concept of change in behavior as it relates to depression from moms from the African and Caribbean community. So to ensure that we are keen about looking at drawing on some of the external learnings about how change happens. So how that would apply within the context of our study is through some of the scales we're using. For example, the PHQ-9 to see if there have been any substantive change at baseline and then at the end of the intervention as it applies to the mom. And we're also trying to articulate our understanding of the change by challenging ourselves in terms of the ways we can explore that change even further. So for example, having actively take part in delivering the session so far, I was keen to understand how these moms see the change that have taken place right from the baseline and through to the end of the intervention. And I was also keen as an active deliverer of the LTP plus to see how that impacts on my delivery of the entire session itself. So it's not just change for the mothers themselves, but change in terms of how we as the facilitator of this training could be part and parcel of that change. So that leads to research questions, which we pretty much try to test or answer through the pilot randomized control trial. First, as it relates to the cultural appropriateness of the LTP plus CBT intervention for treating postnatal depression for British, African, and Caribbean mothers. And the second is the possible treatment efficacy, the cost effectiveness, and the feasibility of scaling up the intervention to a larger sample size. So again, like I said, this is a work in progress. We are still delivering the intervention at this stage, and I'll just sort of speak about, for example, the recruitment criteria and all the other components of it. Next, please. Okay, so the design that we adopted is, of course, a mixed method design given the randomized approach we took. And in total, we had a sample of 120, evenly split to 60 participants per group. So the first 60 are for the LTP plus CBT, whilst the other 60 is for the psychoeducation. And some of the instruments we used for measurements at baseline and, of course, at the end of intervention, as well as 3 months and 6 months follow-up, the Patient's Health Questionnaire, PHQ-9, the GAD, the CISR, as well as the Eurocode 5-dimension to sort of be able to test for the feasibility, the acceptability, and its perceived effectiveness at that stage. So all of this information, so our trial is registered in the trial.gov, so I wouldn't want to take out much of the time. They are very much openly available for those that might be interested in going in a bit more depth. Next, please. Oh, thank you. So in terms of eligibility, the key inclusion criteria includes mothers that might be experiencing emotional distress as a result of childbirth, and mothers that score 5+ on the PHQ-9 questionnaire. And we sort of limit it to mothers having children aged between 0 to 3 years. Again, that's in line with the LTP plus sessions, which spans from that 0 months up until 3 years. And mothers that are able to give informed consent, aged 18 years and above, and pretty much resident here in the UK. for the purpose of follow-up, and they must be from the African and Caribbean communities. Then in terms of exclusion criteria, we exempted mothers that are less than 18 years, mothers who for some reason are unable to give informed consent, and mothers that are temporary residents, and of course, for obvious reasons, they cannot be included because it's unlikely that we'll be able to follow up on them if they were not like permanently resided in the UK. And then we also excluded mothers that, for example, have active suicidal ideations, other complex health problems like heart failure, tuberculosis, and other like really complex, like schizophrenia and all those complex type of problems as well. So we excluded those from participating in the study. Next, please. In terms of the assessment and psychometric tools, including questionnaires that we use, like I said, we did use the PHQ-9 as well as the CISR, which is a clinical interview schedule, the revised version. And we undertook a comprehensive assessment where the mothers were actually given their skills at baseline to complete, and also at the end of the intervention. So we are at the process of rounding up the end of the interventions for all of the groups, but we will be following up 3 and 6 months post-intervention. Yep, so I've talked about the participants, the criteria to be part of the study. Next, please. Okay, so in terms of the key components of the intervention, so the learning through play component is composed of the parenting calendar. And during the course of the delivery, if there is one aspect that the mom loved the most, is the parenting calendar and how they can map out the experience as they go. They found that really, really useful when I was delivering the intervention. And the LTP plus components is low literacy in content. So the moms were easily able to, for example, take part in it. They felt that they understand it. They felt that it was pitched to their level. So that was something that I think is a very good advantage of the LTP plus. And the research-based activities. So for example, I'll give an example of one of the sessions where the moms were told to come up with a diet chart. They really found that helpful. And then when we did like the next week, when I was like, oh, how did you find the diet chart exercise? The positive feedback that the mom were like, wow, I never really thought I could have a proper diet chart with some of the things I've got at home. They found that really useful, and they found, especially with the children components as well, for 0 to 3 years, they found that they learned a lot of valuable parenting skills. So for example, not saying words to the children that would make them scared, and sort of being that role model for their children in terms of some of the things that they can help the children with, some of the ways that they can promote that positive identity and attachment between the mother and the child. So those were some of the very positive aspects with the learning through play component. And then for the CACBT, which is the culturally adapted cognitive behavioral therapy, there were practical activities of how to change depressive negative thoughts to more positive ones. So that, for example, we engaged in role play sometimes where moms will try to see how they can change some of the thoughts that they typically have during the course of the parenting process to more positive ones. So we sort of adopt a year and now approach that takes into consideration some of the cultural norms and that are pretty much peculiar to these categories of participants, and sort of find a more positive way to change those beliefs and to change those attitudes as well. And yeah, it was super helpful, and so far we're getting really, really positive feedback about the CACBT components as well. Then in terms of the second group, which we administered the psychoeducation. Again, it was underpinned by the psychotherapy and general discussions around culture as well as religion as it relates to mental health and parenting. And there was also the components that relates to problem-solving techniques that mom could pretty much adopt to address anxiety as well as maternal depression. So that component as well appears to be very interesting in complementing the LTP plus CACBT. Next, please. Okay, so yes, like a diagram that illustrates the project summary so far. And it's pretty much talked about the process we've gone through in terms of spanning through the recruitment of participants and screening, and down through to the randomization, as well as the assigning of participants into group. So for each session, the sessions pretty much last 60 minutes. And we had a weekly session. So each session contains around 10 mothers per group. So in total, we had 6 groups for the LTP plus CACBT and 6 groups for the control group using the cycle education. So we are now the process of the final stage of the intervention, where we're pretty much delivering the last session and down through to the end of intervention data collection. So we will be also doing some focus groups with the mothers to sort of get their views about the entire process and what they found useful, what they think we could improve on, and all that as well. Next, please. Okay, so in terms of some of the anticipated outcomes from the entire project, we're earnestly hoping that it will be very much instrumental for treating anxiety and postnatal depression amongst moms from the African and Caribbean community, as well as providing them with the very insightful parenting skills that they can use to improve their child's development, and more specifically, help improve the mother's mood, reduce depression, in order to enable them to reach their full potential through that valuable, effective parenting. Okay, and then I think that's the last slide after this. Thank you. So would like to acknowledge the Nottingham Trent University Cure Fund, as well as the National Lottery Fund and the Manchester Global Foundation, and again the Pakistan Institute for Living and Learning that took the time to train us, which I really enjoyed. I did enjoy the training process. And yeah, the National Institute for Health Research that helped with some of the fundings we use for the PPI events, and to our research mentors, Professor Nusrat Hussain from the University of Manchester, and Professor Clifford Stevenson. So below are some of our team members that have been very, very instrumental to the success of this work. So their names are just long but to acknowledge, but I really want to commend each and every one of them for their support during the course of the research process. Thank you so much. Thank you.
Thank you, Torella. This has been very interesting and helpful. And I think that we need to give you the prize for having the most letters after LTP plus. There's 7. So next year we can have a contest to see who can have the most letters be after LTP plus. It'll be very intriguing. But anyway, that's thank you so much for this presentation.
Thank you.
So we're delighted to have Dr. Ishrat Hussain with us here, and Ishrat is a clinical scientist and staff psychiatrist in the General Adult Psychiatry and Health System Psychiatry Division at Centre for Addictions and Mental Health in Toronto, Canada. He is assistant professor in the development of psychiatry at the University of Toronto. The primary area is investigating novel treatments in mood disorders by conducting clinical trials that incorporate the use of putative biomarkers to determine the neurobiological underpinnings of both depressive disorder and bipolar disorders. His current focus is determining the role of anti-inflammatory treatments for mood disorders. Ishrat, we're so pleased to have you with us. Welcome, and it's over to you.
Thanks, Andrew, for the kind introduction and the organizers for inviting me. So alongside my interest in biological psychiatry, I also have a focus in development and investigation of scalable psychological interventions for mood disorders, because I do appreciate as a clinician and physician first and foremost that mood disorders are a heterogeneous group of conditions. So we need to really target them from all aspects. And I'm going to spend the next 10 minutes speaking about how we've used LTP and adapted it in Pakistan to target depression in fathers, but also to improve outcomes for children. This is work that's truly a global collaboration between CAMH here in Toronto, the Pakistan Institute of Living and Learning, and funded and supported by Grand Challenges Canada. Next slide, please. So to just tell you a little bit about the scale of the problem that we are dealing with in Pakistan specifically, Pakistan is one of the most riskiest places for children and riskiest places to be born, unfortunately. For every 1,000 babies that are born, 46 die before their first month. It's a large population, lots of social, cultural, political issues, economic disparity, leading to a lower life expectancy than high-income settings, and a very high degree of poverty, with a third of the population living with limited financial means. There's also a lower literacy rate of around 58% in the population. And then these social, cultural, economic factors really lead to quite a high prevalence of mental disorder. As children grow up into young adults and then working age adults, the prevalence of common mental disorders, specifically mood disorders and major depressive disorders, is very high, much higher than the rest of the world when you look at comparisons with high-income settings. For instance, in men, estimates on the prevalence of depression are anywhere up to 42% of the male population, and in women, the prevalence is around 25 to 37%. And this obviously has downstream effects on offspring and on children of Pakistani adults who suffer from mental health conditions. From our work and work from others in Pakistan, we found that poor mental health leads to poor socio emotional development in children, and also poor physical development. Up to 37% of children in Pakistan are stunted in their physical development. So it's a crucial issue, and something that PIL is trying to address is improving outcomes for children by improving parental mental health. And LTP really has been a huge part of improving parenting, child outcomes, but also integrating that with evidence-based psychosocial interventions for depression, like CBT, to improve outcomes for parents. So much like the talk we've just heard about combining LTP with CBT, we took this approach for depression in fathers, which traditionally is an understudied group, not only in Pakistan, but more broadly worldwide as well. Depression in fathers is not something that's usually identified and not usually as a result treated, and then and very under-researched as well. And in Pakistan, which is specifically traditionally a very patriarchal society, it's even more so an area of neglected research. So really proud of the team to be taking this work on, as I think it really will have some important impacts as this area develops. Next slide, please. So our solution, given the scale of the problem of depression in the male population in Pakistan, a lot of these males are obviously fathers. Our solution was to try and integrate a parenting intervention, as I said, with a psychosocial intervention to target not only fathers' mental health, but also really develop a multi-generational intervention that focuses on both parents, but also child development, while at the same time addressing stigma, because in a setting like Pakistan, mental health is not an area that's usually talked about. It is an area of stigma, and we really tried to focus any intervention that we developed as a training program rather than a treatment or therapy. And we also are hoping to digitalize this to really scale up the program. This slide shows a group of fathers who were first involved in our pilot feasibility study. They're there holding the translated LTP calendar during one of the group sessions of Learning Through Play Plus, which is an intervention, as I said, using the LTP program. Next slide, please. So this was a feasibility that was self-funded by PIL following a work we were doing using LTP in mothers. Really, it was born out of a request from the community. Fathers would be approaching the research team asking whether they could become involved in a similar program. And as a result, we were able to develop a feasibility study looking at a group parenting intervention for depressed fathers. This was the LTP Plus Dads program. So it, as I said, combined the Learning Through Play calendar with culturally adapted CBT, using the Thinking Healthy program as a template for the evidence-based CBT. Next slide, please. So these were the results of our study. As I said, this was just a feasibility study. The main outcomes were to address the feasibility of the LTP Plus program and acceptability. We were able to show, however, even in our feasibility study, significant improvements in postnatal depression scores as measured by the Edinburgh Postnatal Depression Scale, as well as the clinician-rated Hamilton Depression Rating Scale. You can see a reduction of almost 5 points on the Hamilton 3 months after starting the LTP Plus program. And this was sustained up until 6 months follow-up. So clearly LTP was something that the fathers found beneficial, and that improvement appeared to be quite sustained as well. And the improvement also spanned towards knowledge and attitudes. So the KAP is a knowledge and attitudes questionnaire, showing improvements in attitudes towards sense of self, physical development, relationships, as well as in overall functioning. You can see here that generally the fathers that were recruited on the table on the left shows the monthly income. They were of a lower income households with a mean number of children of 3 to 4. So relatively large families as well. Next slide, please. So this feasibility work was very encouraging for us. We then extended it to a larger cluster randomized controlled trial in which we randomized union councils or villages in Karachi, Pakistan, which is Pakistan's most populous city. We were able to recruit and randomize 357 fathers. It was a 2-arm study in which Learning Through Play Plus Dads was provided in addition to treatment as usual. Now, treatment as usual in Pakistan for these fathers really doesn't comprise of much. If they are seeking medical attention, it's usually very brief visits with a family physician. It's very rare that they would be able to access specialized mental health care or any form of psychotherapy. Our intervention consisted of 12 sessions of group learning through play plus dads over 4 months. And we did this very similar assessments to what we did in our feasibility study at baseline, 4 months and 6 months. And our primary outcome was depressive symptoms as assessed by the Hamilton Depression Rating Scale. We also assessed anxiety, quality of life, self-esteem, and knowledge and attitudes towards parenting. Next slide, please. So again, we were very encouraged by our findings. We were able to show a statistically significant reduction in depressive symptoms compared to treatment as usual. And there was a difference of over 5 points in the Hamilton Depression Rating Scale, which is clinically significant as well as statistically significant. And this improvement did maintain at 6 months as well, although not as large as we would have hoped by the 6-month point. Also, fathers in the Learning Through Play group showed significantly improved quality of life and positive attitudes towards child development at 4 months compared to standard care. And again, these are just some pictures of the groups that we undertook. We really did try and do outreach in the community, try and met fathers where they were to enhance the acceptability and adherence to the intervention. Next slide, please. So this work has then led to a very large, very ambitious project, which is co-led by my colleague, Professor Naseem Chaudhry at PIL in Pakistan. This is a transition to scale project funded by Grand Challenges Canada, in which we are really scaling up the LTP program across Pakistan, focused on fathers, but also bringing along mothers as well. It's a partner inclusive approach towards targeting parental mental health in the hopes of improving child outcomes. So as I said, it's an ambitious project. We are hoping that we'll be able to train over 4,000 community health workers in the LTP program. We're also going to include mothers in this project and are hoping to deliver LTP Plus to over 2,100 mothers across Pakistan. And as I said, a large part of this is capacity building so that we really integrate the LTP program into routine care in Pakistan. Next slide, please. In terms of our current progress, this is something that is actively recruiting at the moment. The team is working hard on the ground despite challenges of the Omicron variant at various points and the current heat wave in Pakistan. We've been able to consent over 1,300 fathers. We've already completed baseline assessments on over 1,000. And some of these dads have already completed their 4-month follow-ups as well. And at the same time, we're not leaving behind moms. We've been able to consent almost 1,000 mothers, and over 800 have already completed baseline assessment and started the intervention. And this is really a testament to the hard work that that PIL and our partners in Pakistan, including HANDS, are undertaking at the moment. Next slide, please. So as I mentioned, a huge part of this is the scale up of the LTP intervention and the capacity building at really integrating learning through play in the curriculum for nurses and midwives in Pakistan. These are some photographs showing the training that's been completed. You can see the very proud students holding up their certificates. And so far, we've been able to train almost 300 facility-based health workers. So these are people that are working in hospital settings, clinics, and so forth. And then over 400 non-facility-based health workers are also being trained. And these workers really are the crux of community medicine in Pakistan. We're talking about the community health workers there who really reach out and meet families in their own homes and form a huge part of the care that's delivered locally. Okay, next slide, please. And that's our progress so far. Similar to the work that's being conducted in Nigeria, our aim is to really improve parental mental health outcomes for parents, with the view that this is going to improve socio-emotional and physical development of their children, and really impact public mental and physical health in Pakistan. And we think that LTP is a great way to and low-cost, scalable way to address this issue. So we'd like to thank our partners. We'd like to thank the Hinks-Delcrest Center and now the Sick Kids Community Mental Health Center for allowing us to adapt and use the LTP program to the Pakistani context and really scaling it up. They've been very helpful. Specifically, I'd like to thank Andrew for all of his time and effort and hard work and in really advocating for this and for the scale up of LTP globally. And these are all our partners locally in Pakistan who've really been instrumental in supporting some of this work. It really is a team effort. Global mental health is a team effort on partnership. So we wouldn't have been able to do it with all this support. So with that, I'll stop and happy to take a few questions for a couple of minutes if anybody has any.
Ishrat, thank you very much for your presentation. The numbers are rather large. I just want to clarify one. You talked about more than 400 non-facility health workers being trained. What would be their normal caseload for a community health worker?
I don't think I'd be best placed to answer that. Maybe my colleagues in on the ground in Pill would. I would assume more than 20 to 30 families at the minimum. Anybody from Pill that would be able to venture a more accurate estimate?
Each community health worker or a lady health worker is responsible for about 1,000 mums.
Oh, wow. So I wasn't even close.
Well, that's what I thought. I thought the numbers are absolutely phenomenal. If you add 400 trained people that have a caseload of that many, that is an incredible reach. Wonderful. Yeah. I was also
we're targeting 4,000, Andrew. So the hope is that
those numbers are just too big for me. I can't take them in all at once. I have to look at them on paper. See, no, that's great, wonderful. The other thing that strikes me is the number of partners that you had, their logos there below that on their last slide. That's really quite remarkable that you've got that kind of international collaboration going on. It's wonderful. I think we have time for one more question. Is there? Robbie,
James Barber has raised his hand.
Okay. Yes, yeah. James.
Yeah, Ishrat. So a quick question. I know you're really keen on getting to the dads and also the mums at scale. Have you thought any more about doing more on social media or gamification of the content, given that you do have the issues of people feeling, hesitant, social stigma. I don't know what it's like in Pakistan, but I think globally we're a little over half of the world has access to social media. Is that playing a bigger role? Because we seem to be a long way down the path of using the traditional healthcare and mental health services and lady health workers that are there, but a lot of people are solving their day-to-day problems in other ways.
I think it's a very good point, James. And I think harnessing technology, and particularly smartphones, is definitely something that we're considering for this. I think something like over 90% of the population has access to a smartphone. I'm not sure about social media usage and sort of using that. We're definitely using that to disseminate information about the project and trying to enhance recruitment. But we're thinking of digitalizing this to be able to harness that smartphone technology and disseminate it further, because I think it could be very easily digitalized, to be honest. So we're definitely looking at that, maybe like an app-based intervention rather than social media. So far, we've used social media, as far as I'm aware, more for community engagement, dissemination activities, rather than actual harnessing it for an intervention. But that's an interesting approach as well, certainly something to consider.
Thank you, James, and thank you for that response, Ishrat. in closing this particular part with Ishrat, I just want to point out that in the early days, learning through play was picked up by organizations, starting, like it's mentioned, with India. And different groups wanted to just put it in place. But it was PIL in Pakistan that was first into the formal evaluation. And those evaluations and research that came back, the results that came back, really allowed learning through play to expand. At that time, it was called CETA. Was able to give grants then in order for other countries to become involved based on the research done by PIL. So there's much gratitude towards PIL for the work that was been done in the early years, and you can see that it's continuing and expanding. So again, thank you, Ishrat, for your presentation, and we're delighted now to go to Dr. Lynn Jones, and I know that she's here. I could see her. Now I got to tell you a little bit about Lynn Jones. Nothing puts Lynn Jones down, but she's been injured. I think she broke something, and I can see that she's sitting up. But if she has to lay down, we'll have to give her room for this because she's in pain. And now I told her that if this was a baseball game, we've got the bases loaded. We've had such good players here today. We've got the bases loaded, and she's our last speaker, and she's got to hit a grand slam in order to get everyone in. So if you know Lynn, you'll know that she's a whirlwind of activity. It seems to me that wherever there's tension in the world, she finds herself there, whether it's in Haiti after the earthquakes, whether it's in Bosnia. She's written a number of books about her experience, and I can tell you they're well worth reading. And but anyway, she's a child and adolescent psychiatrist and relief worker, and has been engaged in parenting programs in conflict and disaster settings for the last 17 years, and much drawing on the learning through play approach. She's been engaged in assessing mental health needs and establishing and running mental health services in disaster, conflict, and post-conflict settings around the world since 1990. Her latest book is The Migrant Diaries and has been published by Refugee Press in 2021. She's the Senior Technical Advisor in Mental Health for International Medical Corps. She's a course director for the program on mental health in complex emergencies at the International Institute for Humanitarian Affairs, Fordham University, and consults to the World Health Organization, UNICEF, and UNHCR. She was a member of the ICD-11 Stress Disorders Working Group and is a technical consultant to the development of the MHGAP curriculums by WHO and UNHCR. Lynn, we're just so pleased that you're here and that you're able to sit up and talk to us. Thank you.
Thank you, Andrew, for that rather overwhelmingly embarrassing introduction. And yes, I did break my ankle a couple of days ago. I've never broken anything before. It's a really good learning experience for me to be physically confined. My talk is really different because I'm just going to kind of share personal experiences and pretty pictures, which is a big change from the overwhelmingly brilliant speakers that I listened to this afternoon and yesterday. And thank you so much. I'm honored to be in this group. I've learned a lot. I think what I really want to get across is how flexible learning through play is, and show you the variety of ways that I've integrated aspects, and I say aspects of it because I've never kind of gone out and formally done the whole thing, in different contexts. And I've put up here what I'm going to talk about, sort of first starting with how this whole issue started for me. Now, you might think as a child psychiatrist that, is this working? Yes. Are you seeing my slides as slides? You're not seeing my notes, are you? Just quick check. My slides are filling the screen, is that right?
Yes.
Okay, great. I'm just fiddling with my presenter view here so I can actually read my own notes. So yes, this is Tabitha. Oh, it's not her real name. She's a refugee from Darfur. I met her in Chad, where large numbers of people had fled across the border with the beginning of that genocide at that time, which of course the conflict hasn't gone on, the refugees haven't gone home. But Tabitha had abandoned, people came running to me because they're to do a mental health assessment and said, oh, you must meet Tabitha, she's gone mad and she's lost her baby and the baby's dying because Tabitha thinks there's nothing she can do for her. Now what had happened is that Tabitha was starving, the baby was starving, And Tabitha told me that the baby was dying because the baby wasn't responding. What a surprise. We got both of them to the therapeutic feeding center, and they both did well, and food made a lot of difference, as you see in the two pictures. And I wasn't really thinking about infants. I mean, I taught attachment all the time, but I didn't think about infant stimulation programs very much in 2004. I thought about treating depression and psychosis and depressed mums and traumatic stress reactions and so on. But what I noticed in this TFC, as we call them, was the silence. None of the mothers were playing with their babies. They were just sitting there, like, and the baby wasn't responding to the mum. And I thought, got to think about this. And I got some time. I was very lucky. I'm not the mental health advisor to IMC anymore. That ended in 2011. But in those 10 years I was, and they gave me some time to just go and read stuff up, thank goodness. And of course I came across this, which most of you are familiar with, this incredibly famous prospective randomized trial from Jamaica done in the 90s, which showed this extraordinary thing, that actually the ideal thing is to play with your baby and to feed them, of course. But if you can only do one and you've not got acute starvation, I'm not talking about that situation, then guess what? It's better to play with the baby than it is to feed them. I mean, I'm not saying you shouldn't do both, but it was very interesting that the babies who got the stimulation alone intervention did slightly better than the babies who got the supplements alone. That was so interesting to me, and I began to read more and think more. And of course, I learned about maternal depression and its relationship to adverse environments and its relationship to play. And there was so much good research by people I actually knew quite well, like Atif Rahman, Professor, and Vikram Patel. And I just thought, we have to start programming around this. Now, of course, I wasn't the only person having these brilliant ideas, because learning through play already existed, I think. WHO had just produced these guidance notes. Amazing. They're saying, when you're feeding, you should stimulate. And I said to my agency, we should be doing this as an emergency intervention. It's just as important as food. This is not just for your normal city life, your normal low development situations, whatever. This is for emergencies. This is an emergency intervention, and I want to invent really an emergency intervention. And it was certainly needed. And luckily, I'd just been sent to Uganda, where we were doing, as usual, full-scale mental health assessment. And one of the things I thought I would incorporate into my assessment for the first time with an ethnographic, and I do it all the time, no one wants my protocol, they can have it. Sit down and I talk to mums about how they understand child development, do they play with their babies, what do they do to help their babies grow? It's basically, that's what I do. And guess what? One of the things I learned is that IDP mothers in northern Uganda had stopped playing with their babies, as this mother says so eloquently in this slide. That's not her 2-year-old, that's a random child in the TFC, but it sort of sums it up. I don't play with my children, I don't tell stories, I've forgotten how to play with them. And what does he do? He goes away, doesn't play himself, gets into fights. It's a heartbreaking quote that kind of sums up what happens to children in emergency settings. So, amazing woman from UNICEF is sort of hanging around and saying, okay, you want money, what do you want it for? And I said, I want it for an infant stimulation program. And she said, okay. And I said, I'll find some materials to use. And she said, okay. And she said, well, if you're going to do this, it's not been done that often in an emergency. I think you should research it. And for a donor to say in an emergency that they will give you money for research, that's pretty astonishing. So I said, yes, give me the money. And then I asked Atif, and Andrew, I don't know how we connected, but anyway, I asked Atif. He said, look at what they're doing in Pakistan with lady home visitors, which you've heard about in full. It's completely brilliant. They're using this stuff called learning through play. I think it's the best intervention on the planet. Why don't you use that? So somehow this connected me to wonderful people in Canada, Andrew and Miriam Riza, and they connected me to the Sick Kids Canadian and Hinks Delcrest, who gave me, thank you, because it was free, we couldn't have done it otherwise, gave me not just the right to use the calendars, because they didn't exist in Echoli, of course, which was the language we were going to work in, but to adapt them. Because I said, I'm going to take a slightly different approach. They said, fine. And I did. And that's what I'm going to tell you about. Oh, I just want to tell you about this picture, actually. I love this picture because we got a slogan together for our program, which is love, play, communicate. And I still use that. that sums it up for me. I use that across the world. But that woman in the picture, I use it everywhere because she's doing that. If you would like to know how Acholi mothers help their children sit, Acholi children sit at 3 months, not 5, not early. And one reason is they put them in the washing bowl, they pack clothes around them, and then bit by bit, they take the clothes away. And she was demonstrating how she did this for me. And also she was showing love and playing and communicating. And she's my symbol because she was inspiring. So we developed, yes, I know, bit shocking, a 6-session intervention for groups. Now that was because groups of mothers, we could cover more mothers, 6 sessions, mothers come and go in conflict and IDP situations. And we really had to have something that worked. And we did it as a controlled trial. So some mothers were waitlisted in some communities and other mothers got the intervention. And there's a full paper on this. I'm sorry, all of you so impressively showed your papers. Rabia has it, and if anybody wants it, she can circulate it. These were basically the sessions. Andrew, will you give me, I can't see my clock at the same time, so will you give me a 5-minute warning?
Yes, we will do that. Carry on, you're doing great.
Okay, great. These are 6 sessions, starting with, I really was grateful to the Learning Through Play manual, which I read and consumed. I must also express gratitude to the WHO manual, which was coming out at the same time. And I kind of combined them to write our own psychosocial nutrition manual. Now that was written in 2007 and I thought, shall I send that to you? I haven't, but to tell you the truth, I do still use it. And again, those manuals that you both organizations produced, incredibly useful. So we start with an introductory session as to help mothers understand what's the brain and what is child development. Then we have a session on what's play, and I love the LTP material on this. And we have a session on making toys. But first of all, of course, mum's the most important toy, but then guess what? You can make toys from rubbish. And I will tell you, across the world, from that year to this session has always been like the most fun session, and it always brings mums back, and they come back with more homemade toys. It's absolutely brilliant. And then we do physical development. I mean, I could do a training session on all of these, but in the physical development session, I have incorporated the work of an amazing woman called Veronica Sherborne and something called She Calls Developmental Movement. I haven't got time to teach you about that, but I was lucky enough to have her teach me as a medical student. Look up Veronica Sherborne Developmental Movement and you'll see what I do in this session. Then, of course, love, attachment, relationships, so important. Thank you for the great sessions yesterday. I'm going to be stealing some of your materials to improve on these sessions. And then we combine the sessions on communication and understanding. And then I have a very important session, and you know how important, again, you've discussed this, the parenting one yesterday. Thank you. Harsh parenting has become understood to be one of the big issues. I will tell you that the annual review from UNICEF showed that the big issue for mothers and parents, it's not so much PTSD, it's what stressed mothers do to their children, because in every refugee situation in which I work, I find that punitive discipline goes up, and it starts young. So teaching children to be good in a positive way has become a very important session. Now, these aren't the LTP sessions, but I use the LTP materials. I love the Q&A format. We take the pictures, we adapt, we wander around, we find a local artist, and we draw local children, local scenes, and we adapt them culturally. And then we take the Q&A format. So this is some of the pictures from one of our first sessions. We have a picture like this. If I've got a mum and if fathers want to come, they're welcome, and father in the room, I'll be pointing at them rather than the picture. If I haven't got anybody doing what I want in the group, I'll use the picture, and we use the questions, and then we give the answers, both in pictures and through call out. And then, I had a lot of discussion with Miriam about this because she thought it was strange at the beginning, but she was very helpful and I explained what we want to do. If you've got a group, the LTP calendar takes you through all the developmental issues on one page for one age group. We completely turned that upside down, and I've given you the example of teaching communication, and we took all the age groups and we put them on one page, and we did one theme per page. If anybody has a question about that and I'm not making myself clear, please come back to me. I hope this illustrates how I would do a half group session on communication using the pictures going age by age in the group. But actually, I use the pictures as prompts because what I'm looking for in the group, obviously I'm not going to have a goat in the group, but I'm looking for the mothers to tell me how they teach communication, to show me how they teach communication, and reinforce with examples from the pictures. I hope that's clear. Here's some pictures from teaching on relationships and attachment. And the one I showed you before, that was from Haiti, our Haiti calendar again, culturally adapted pictures. This is from the calendar we developed in Ethiopia for Somali mothers. And so again, we are taking situations and pictures that fit the situation. Now we also added to the calendar things that aren't, I haven't seen LTP plus, so I don't know if we're tackling this, but I told you positive discipline was incredibly important. So what I would do in my ethnographic work was ask mothers, tell me a situation where you might have to really discipline your child. And then I'd say, how do you do it? And guess what would come up from Guatemala to Uganda? Well, there are some times when I do have to beat the child. Oh, what? Well, for example, you know, this is a camp and we have to keep things clean. And if my child goes and shits, excuse the word, outside the house, I'm going to have to beat him. And everybody understands that. And so we make pictures for that situation and then we discuss what could you do instead? And we make pictures from that situation. And that leads to lovely discussions in the session. You know, well, perhaps I could ask the child to help me clean up. That's a consequence. And explain to him what he has to do. Now, all those pictures come out of discussions with the mother and then get fed back into group discussions with the mother. I hope that's clear. We also have a whole, in the play session, before we even begin play, because mothers are living in these quite chaotic situations, we put quite a lot of emphasis and illustrate it on making play safe. You know, have a clean mat, get all these dangerous things out of the way. Of course, you're not going to play with small objects that children can swallow, etc., etc. As I said, what I want to do is just share some of my experiences around the world. But as I told you, making toys from rubbish has been like top session in every country. And I just thought I'd share these pictures from using it in Belize a couple of years ago, where the mothers came back with, we had a session and then the next session they all came back with toys they'd made themselves, glove puppets, the boxes filled with rubbish that make bricks, beautiful mobiles, and I just was so impressed. This is also one of my favorite stories because this mother was one of the first, it was in my ethnographic assessment period, and we were talking about toy making and I was showing with plastic bottles how you could make rattles. And they said, very nice, yes. And the next day I came back to the stabilization center and this mother, who had quite a sick child, had made this toy, which she'd hung across her bed. Absolutely brilliant. And the next day I came back and all the mothers had copied her. So I learned from mothers all the time. Here's another picture of Somali mothers making toys, cardboard jigsaws. And with, I think, grand challenges, it's a little bit, this is 2008, I think we got money from the Canadian government to take learning through play to the borders of Bogota City in Colombia. We worked with the World Food Programme, integrating into their nutrition program there. And here we've got, again, the toy making and playing with children. And we worked specifically with IDP mothers from the Highlands who became trainers themselves. And I had enough money to really work on training those mothers to deliver as a group and as a home visit intervention. They love the materials. And when we do home visits, we then have the calendar and the mothers get the calendar as a gift. We did it in Haiti after the earthquake. And here I had the funding, thank you very much. I think the World Food Programme helped us as well, and UNICEF, to really push a relatively new idea in 2010 that everybody comes in, and there were 60 agencies, I counted, setting up child-friendly spaces. Well, what's the trouble with a child-friendly space? It's absolutely full of 3, 4, and 5-year-olds hurtling around, and you can't do a mother and baby group. You can't do a father and baby group. You can't breastfeed your baby there. We said, we want baby tents, and we got them put up, and they were protected spaces where mothers and babies, fathers and babies could come any time of day. We had the ECD kit that UNICEF had just made and tested. Lovely, lovely, lots of toys. We had a breastfeeding space, and we ran our groups there. It was a lovely place.
5 minutes, Lynn.
Thank you. That's going to work fine. I've only got 5 more slides. UNICEF, as a result of this work, were kind enough to ask me to write a guidance note. You can still find it online, though you have to dig a bit. But basically, the Somali famine was going on at that point, and they said, Lynn, write a guidance note about why you should integrate ECD into nutrition programs. And it was really one of my proudest and most honorable achievements, because it got me to say all the stuff I'd been saying for the previous year, say why, what, and how. And of course, I referenced the wonderful LTP material. And it wasn't just me writing it. I mean, I was the author, as they say, but there were 7 or 8 agencies involved, and we met frequently to agree, and that document was used. It's dated in terms of its research, but the message remains the same, as you know. I was very happy to take this with Aga Khan to Mozambique, which was my first non-emergency situation. And I worked across the northern tragic area now because of the conflict that's emerged recently. But at that time, it was relatively peaceful, and we worked in small communities, setting up LTP groups. But then we were hit by a cholera epidemic. And I realized for the first time, it's not just about nutrition. Not for the first time, I thought, we have got to integrate physical health into our psychosocial mental health intervention. So I was kind of going back the other direction. I'd been adding these programs to nutrition programs, but now I thought, no, in these group sessions, we'll have more sessions and we'll integrate physical health. And of course, hand washing in a cholera epidemic is pretty radical. I also have become incredibly flexible about where you can do these. And, it was the first time in Mozambique that I learned to sit down in a field where women were harvesting. They bring their babies on their backs. We take a break and we say, let's do some stuff around this. In Belize, where I worked 2 years ago, in Punta Gorda in southern Belize, Maya population in the hillsides, they have a wonderful maternal home visit program, but they weren't doing much on infant stimulation. So they let me both sit at the table when they were doing their vaccinations or from the back of the car. And they also said, here, use the other half of the room, set up a group. And it was great. I had a captive audience. They were getting the physical health side. And I added in the group intervention. I really want to push this because we've talked a lot about maternal mood. And I think the last speaker made clear how beneficial groups are for fathers. And I think delivering the LTP or any kind of infant stimulation intervention in groups is really powerful, because in groups, you really do get to address other issues apart from infant stimulation. We found from our research intervention in Uganda that maternal mood improved. And I would argue that that was from the social connection that came through being in a group. One of the women in one of these pictures had severe mental illness, but as she recovered, she wanted to come to the group and hang out with other mothers. And her relationship with her child improved her mood. Her relationship with the women improved her mood. Secondly, of course, you get to share. As the woman in the other picture from Mozambique, she is teaching me the baby massage techniques, and she's teaching other mothers the baby massage techniques that all mothers learn to help their child's physical development. Groups really make a difference. This is the last slide. I've just come back from northern Ethiopia working with Amhara, a population massively displaced by the recent conflict, very tragic situation. I, with International Medical Corps again, was invited with my husband to do an intervention. And this time, uniquely, and the first time, and we're going to be doing this again in Venezuela, we mixed teaching physical and mental health. We've got the core components of the LTP approach, but added to that, child's physical health, vaccination, nutrition, mother's mental health, and mother's physical health. So in the same 10, it's now 10 sessions, obviously, in the same group that where I'm teaching mothers about stimulating their babies, I'm teaching them to I'm not, my husband does it, to examine their breast to look for breast cancer. And the one complements the other, because a mother who's worried about a lump in her breast, and I've encountered her, isn't focusing on her baby. If we're telling her what to do about the lump in her breast, she can pay attention to her child. Maternal and child health needs to be an integrated package. That is the end of my presentation. Thank you so much for letting me share it with you. I'm going to close it.
Lynn, you hit the ball out of the park. Good job. There was a couple comments that people wish you didn't have to stop. So I think I encourage you to.
We've got 2 minutes for questions, haven't we? A couple of minutes.
I think
Good.
I think we can take one question or so, Nusrat. Is that
Yeah.
your reading?
Yeah, let's take one question. I would want to talk about also where we are going to take this, and we have got 10 minutes to finish. So let's take one question. Anyone or
Can I just ask, what are the baby tents? What are those safety baby tents, Len?
Well, just a tent. I mean, basically, the point is, if you're in emergency, everybody's very familiar with the concept of a child-friendly space, and that's needed. And it's funded and everybody does it, but it will be focusing on the needs of the active child, which tends to be 2, 3 and up. And that will not give you the space physically or protected. A mother with breastfeeding her baby, or to whom you want to teach, empathic, interactive play, you can't do that if there's the 3 and 4-year-olds hurtling around kicking footballs. So you need a baby-friendly space. And that's becoming a common funded intervention in emergencies. If you write a proposal saying, I want to create baby-friendly spaces, we'll be teaching infant stimulation, blah, 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 that makes sense to people. Whereas 10 years ago, people said, well, you've got a child-friendly space, why are you fussing? I said, no, I need a safe space for babies. Do you see what I mean? Where mothers and babies can come. Because remember, they're living in squalid little tents in an IDP camp. They haven't got space to wash, and especially as I've been working in the migrant community where they've got nothing at all, because the big agencies aren't there, it's even more important. Yeah.
can I suggest something, Andrew?
Yes.
Yes. Maybe we can do our bit. I would need to go at in 8 minutes, but maybe some of you can continue and have your discussion.
Yep.
Would it be okay, Andrew, if I make a start on it?
Yes, go ahead. Yes.
One of the things I'm very keen to talk about is, could you take it to the next slide, Arabia? The one, yes. You've heard talks from Safa, then Naseem talked about refugees from Afghanistan and Pakistan. They've worked on that learning through play. Dung is working in Nigeria, and also we are looking at in Bangladesh. I think one of the things I wanted to talk about is what we are seeing in Europe right now, and a number of people, I'm having discussions with how we can be responsive to this extremely rapidly growing public health huge issue about the refugees. And as Safa said and Dung said, there are large numbers who are women and children, refugees in Poland, refugees in Romania, Hungary, and elsewhere. With Safa's work on delivery of LTP Plus online, which he had to do because of the COVID, I think this is something which we have learned, and like Andrew was also talking about, or James also alluded to, how we can increase access by using technology. I am having some conversations about how we are going to deliver this intervention to millions of parents and children, refugee in different parts of Europe. And I just wanted to bring it to you because I would be reaching out to a number of you because we would need help, particularly who are able to deliver the groups. I've already received some funding from Manchester Global Foundation, and I am having conversations with other funders how we can take Learning Through Play Plus forward. The pictures are of a training in EMDR, which Safa conducted with a colleague of mine, Shiraz. So we are looking at if we could do LTP plus EMDR, but a number of people have talked about one size does not fit all. So we would be looking at what other things we can do. So this is one thing I wanted to talk about. The other thing, the reason of having conversations with Andrew and organizing this event is because it is being LTP plus is been going on in a number of countries. So the ones which we have heard yesterday and today is probably a smaller number of countries and areas which we have looked at. They were other colleagues like in Jamaica, in Colombia, in Philippines, and many, many more, which Andrew knows better about. So looking at how they can be a support network, and that was the reason of inviting people. And we can look at how we can further scale up and develop our acknowledgement and gratitude to Sikh kids. They have been quite open about they want to support this. They want to support the scale up. But at the same time, I can relate to what some of the concerns are, is about the fidelity of the intervention. Because learning through play is being delivered in different ways. In some areas, it's in countries and presentations we have heard, it's LTP plus something bit, but looking at how much it is LTP and what is the plus. All these areas are important with regard to, we have heard about physical health issues as well. Lynn's presentation about supplement and stimulation, a clear case for what is important. So that was the reason we thought we should come together, look at if we could set up a network, a consortium. We are talking about how we can meet a bit more regularly. Maybe every 3 months, we can invite people like Maya to deliver a workshop. We are talking about an annual conference. So we can look at looking at learning through play primarily, but looking at overall parenting and what is required in different parts of the world. And I would like to, thank Andrew, Rabia, and so many other members of the team who have been brilliant. We are very grateful to all the funders. As we could see from different presentations, there are different funders who have supported this program. But looking at where do we take it, do we need to have conversations with UNICEF? The Bangladesh program is being supported and funded by Save the Children. We look at, we are very grateful to Barber family, who has really helped take this to the next level. Bringing all that bit, and this has been recorded, we would continue to hopefully stay engaged and get your comments of taking it forward. So back to you, Andrew, and brilliant speakers. Thank you, everyone.